Assalamualaikum, Mas Kamil, kedengeran nggak suara saya? Assalamualaikum, Bu, suara saya kedengeran nggak, Bu? Mas Kamil,
Kedengeran.
jelas nggak?
Jelas.
Jelas ya. Maksudnya nanti kalau acara yang dengan moderasi itu saya jadi moderator, insya Allah bisa ya kedengeran ya. Halo, halo, Mas Kamil, jelas ya?
Sudah, Bu.
Iya. Itu suaranya mantul ya, Mas Kamilnya mantul. Ya udah kalau udah.
Double, Bu. Tadi ada yang nyalain double. Suara enggak kan?
Nah, ya udah kalau udah ya udah, alhamdulillah, berarti suara saya udah kemarin soalnya udah dibetulin sama Atrio, kan suara saya suka hilang kalau di ini. Nah, udah, thank you. Udah ya, thank you ya.
Siap. Tes. Tes.
Tes. Ada nggak, Pak? Tes. Assalamualaikum warahmatullahi wabarakatuh.
Kedengeran. Mesti coba tes, coba. Kedengeran kok.
Nggak ada dosen.
MC Karimah.
Hadiro Ibu.
Indah, kedengeran kok, kedengeran. Bismillah ya. Semoga sukses ya.
Iya, Ibu, makasih.
Bismillahirrahmanirrahim. BTW jangan lupa mic-nya di off kalau nanti bicara ya. Nah, kalau lagi itu di public baru di on.
Tes. 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 Tes satu. Wih. Jangan tegang. Satu, satu, dua, satu. Assalamualaikum warahmatullahi wabarakatuh. Welcome in the first Muhammadiyah Public Health and Medicine Conference.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Mr. Kamil.
You are welcome, Ibu.
Ya, thank you, Mr. siapa ini? Mr. Kamil.
Ibu Andri.
masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah untuk di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah untuk di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah untuk di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah. Mengapi padamu, sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah, mengapi padamu, sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah, mengapi padamu, sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah mengapi padamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah mengapi padamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah mengapi padamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah mengapi padamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah menang di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah menang di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah menang di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah mengawi padamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah mengawi padamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah mengawi padamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Tuhan di matamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Tuhan di matamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Tuhan di matamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Tuhan di matamu. masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Tuhan di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Tuhan di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Tuhan di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Tuhan di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah mengerti padamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah mengerti padamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah mengerti padamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah mengerti padamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta matahari melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Nabi Madamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Nabi Madamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Nabi Madamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Nabi Madamu. Sehatlah jiwa raga kita, bangunlah gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Tuhan di padamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa.
Iya, bahasa Inggris. Kan bahasa Inggris. Ya, ini aja.
Tes.
Please pay attention. We need to convey to the estimated audience that the event will start soon. Before starting the event, I would like to read some of the participants' rules during the event. It is expected for all of conference participants. Don't forget to fill attendance provided by the commit. You can find the link at the column chat Zoom. Turn on the microphone and turn on the video during the event. And when it closes, if anyone to ask, you can click the raise hand button if needed. Participants are prohibited from spamming chat in the chat column.
For the announcement for this conference, we'll have it 2 days. They're on Thursday, 29 July 2021, and tomorrow on Friday, 30 July 2021. Thank you. Bismillah, Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh.
Alhamdulillahirabbil alamin wa bihi nasta'in wa ala umuri dunya waddin wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi wa ashabihi ajmain amma ba'du.
His Excellency Chancellor of the University of Muhammadiyah Jakarta, Mr. Dr. Makmun Murad Albarbashi, Master of Science.
The Honorable First Advisory Board, Mrs. Dr. Andriani, Master of Public Health, as Dean of Faculty of Public Health, University of Muhammadiyah, Jakarta. The Honorable Second Advisory Board, Mr. Dr. Fahri, Pulmonology Specialist, as Dean Faculty of Medicine and Health, University of Muhammadiyah, Jakarta. The Honorable Third Advisory Board, Mr. Baikuni, Bachelor, Master, and Doctor of Philosophy of Public Health, as the President of Indonesia Public Health Association's Jakarta Region.
The Honorable Chairman of First Muhammadiyah International Public Health and Medicine Conference, Mrs. Munaya Fauzia, Bachelor and Master of Public Health.
The Honorable First Speaker Conference of Public Health and Medicine Conference, Mr. Dr. Safiu Bayu, Doctor of Philosophy, Master of Business Administration, Bachelor of Medicine and Bachelor of Surgery, Master of Public Health, FRSPH from University of Toronto Institute for Pandemic Canada.
The Honorable Second Speaker Conference, Mr. Calvin De Los Reyes, Doctor of Philosophy from University of Philippines, Manila, University of Ryukyu, Japan.
The Honorable Third Speaker Conference, Mr. Dr. Abul A'la Al-Maududi, Pulmonology Specialist, Faculty of Medicine and Health, University of Muhammadiyah, Jakarta. The Honorable Fourth Speaker Conference, Mr. Dr. Rizky, Pulmonology Specialist, Faculty of Medicine and Health, University of Muhammadiyah, Jakarta. The Honorable the Fifth Speaker Conference, Mr. Febi Dwi Rahmadi, Master of Public Health, Doctor of Philosophy from Griffith University, Australia.
The Honorable Steering Committee and all of the participants of Public Health and Medicine Conference, which can mention one by one, but hopefully it will not reduce our respect.
First of all, in the name of God, Allah Subhanahu wa Ta'ala, who has given us mercies and blessing, who has given us health and the opportunity so we can be here and meet virtually through a Zoom meeting today on Thursday, 29 July 2021, in the first Muhammadiyah International Public Health and Medicine Conference. In this conference, we have the following themes: management for tuberculosis control during COVID-19 pandemic.
Before starting the event, let me introduce ourselves. My name is Dinda Hasnatul Salsabila and my partner,
Karima Az-Zahra.
We are the Master of Ceremony Conference today, so allow us to read several sequences of our agenda today.
For the first agenda is opening.
The second agenda is reading Holy Quran.
The third agenda is singing Indonesia Raya and March Faculty of Public Health, University of Muhammadiyah, Jakarta.
The fourth agenda is welcome speech.
The fifth agenda is the main event, the presentation of conference material, discussion, question and answer, which will be divided into two sessions.
And the sixth agenda is closing.
Those are our agenda this morning. For the first agenda is opening. Let's we open our agenda by reciting Al-Basmalah together. Bismillahirrahmanirrahim.
The second agenda is reading Holy Quran, which will be read by Mr. Dr. Suherman, Bachelor and Fisheries, Master of Science, and Sister Zahra Mufida. Time is yours.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
A'udzu billahi minasy syaithanir rajim. Bismillahirrahmanirrahim. Ya ayyuhalladzina amanu taqullaha haqqa tuqatih ولا تموتن إلا وأنتم مسلمون واعتصموا بحبل لله جميعا ولا تفرقوا واذكروا نعمة الله عليكم إذ كنتم أعداء فألف بين قلوبكم فأصبحتم بنعمته إخوانا وكنتم على شفا حفرة من النار فأنقذكم منها كذلك يبين الله لكم آياته لعلكم تهتدون ولتكن منكم أمة يدعون إلى الخير ويأمرون بالمعروف وينهون عن المنكر وأولئك هم المفلحون ولله ما في السماوات وما في الأرض وإلى الله ترجع الأمور صدق الله العظيم.
I seek refuge in Allah from the accursed shaitan's temptation. In the name of Allah, the most beneficent, the most merciful. O you who have believed, fear Allah as he should be feared, and do not die except as Muslims. and hold firmly to the roof of Allah all together, and do not become divided. And remember the favor of Allah upon you when you were enemies, and He brought your hearts together, and you became brothers by His favor. And you were on the edge of a pit, the fire, and He saved you from it. Thus Allah make clear to you His force, that you may be guided. And let there be a rising from you, a nation in fighting to all that is good, and joining what is right, and forbidding what is wrong. And those will be successful. To Allah belongs whatever in the heavens and whatever in on the earth. And to Allah will all matters be returned. Allah is righteous in all His words. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you for Mr. Dr. Suherman, Bachelor Master Science, and Sister Zahra Mufida, who has read the holy verses of the Quran. Hopefully, was read and listen, get blessings and reward. Amin, amin, ya rabbal alamin.
For the third agenda is singing Indonesia Raya and Mars Faculty of Public Health. For ladies and gentlemen are expected to stand up and turn on the audio for singing together. Thank you.
Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas cita-cita masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah mengapi manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa.
Ladies and gentlemen, are welcome to sit back. Thank you.
The next agenda is welcome speech. For the first speech from Chancellor of the University of Muhammadiyah Jakarta, Mr. Dr. Ma'mun Murad Al-Barbashi, Master of Science. Time is yours.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh.
Alhamdulillahilladzi arsala rasulahu bil huda wa dinil haq liyudhhirahu 'ala ad-dini kullih wa kafa billahi syahida. Asyhadu an la ilaha illallah wahdahu la syarikalah wa asyhadu anna Muhammadan 'abduhu wa rasuluh la nabiyya wa rasula ba'dah. Honorable speakers, Mr. Dr. Safi Yu Huyan, PhD from University of Toronto, Canada, Mr. Kelvin de los Reyes, PhD from University of Philippines, Manila, and University of the Raikius, Mr. Dr. Abdul A'la Al-Maududi from Faculty of Public Health, University of Muhammadiyah Jakarta, Mr. Dr. Muhammad Fahri from Faculty of Medicine and Health, University of Muhammadiyah Jakarta, Mr. Dr. Rizky Akaputra from Faculty of Medicine and Health, University of Muhammadiyah Jakarta, Mr. Febi Dwi Rahmadi, PhD from Griffith University of Australia, Mrs. Dr. Andriani, Dean of Faculty of Public Health, University of Muhammadiyah Jakarta, Honorable Vice Rector, Dean and Vice Dean in University of Muhammadiyah Jakarta, Honorable President of Indonesia Public Health Association Jakarta Region, Mr. Baikuni Kurman, PhD, and also all of distinguished guests. Ladies and gentlemen, firstly, I would like to thank the Faculty of Public Health, University of Muhammadiyah Jakarta, in collaboration with Faculty of Medicine and Health, University of Muhammadiyah Jakarta, and Indonesia Public Health Association Jakarta Region for organizing this important event. I hope this conference can become an annual event or at least once every 2 years. Amin. 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 Ya Rabbal Alamin. Dear attendees, let me first welcome you to the University of Muhammadiyah Jakarta and also to the first Muhammadiyah International Public Health and Medicine Conference with topic management for tuberculosis control during COVID-19 pandemic. Allow me in this context for thanks Earth and every one of you here different countries in this virtual conference today. Ladies and gentlemen, the COVID-19 is considered among global events that have caused major changes to the world since the end of the Second World War. By the end of 2020, this virus has infected more than 60 million people globally and has killed 1.5 million of them. The virus has led to fundamental changes in various areas such as health, social, economy, and political, as well as posing new challenges for the future for the future of global humanity. Tuberculosis control during COVID-19 pandemic may be effective. Management for tuberculosis treatment must be continued in line with the management of COVID-19 pandemic. Ladies and gentlemen, University of Muhammadiyah has proven its strong international orientation by organizing this conference. This also shown in the attention to the practical detail of international mobility. Once again, I will deserve compliment for our host. Applause for host this conference. Once again, applause for host this conference. Ladies and gentlemen, I hope this conference will bring positive messengers and impact. Thank you for your attention. Billahi fi sabilil haq, fastabiqul khairat. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you for our Mr. Dr. Ma'mun Murad Al-Barbashi, Master of Science, for the speech.
Before we continue to the next speech, we will do a virtual photo sessions together. For the presenters and the committee are requested to turn on the cameras. And for the operators are welcome to take documentation.
Okay, please be prepared for take the photo. For first slide. 1, 2, 3. 4. For the second slide. 1, 2, 3. For the third slide. 1, 2, 3. For the fourth slide. 1, 2, 3. Okay, thank you.
For the second speech is from Dean of Faculty, Public Health, University of Muhammadiyah, Jakarta, Mrs. Dr. Andriani, Master of Public Health. For Mrs. Dr. Andriani, times is yours.
Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin. Wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi wa sahbihi ajma'in, amma ba'du. Rabbis rohli sodri wa yassirli amri wahlul uqdatam min lisani yafqahul qawli. The Honorable Mr. Dr. Ma'mun Murad Al-Barbasi, Master of Science, Rector of University of Muhammadiyah, Jakarta. The Honorable Deans and Vice Deans at University of Muhammadiyah, Jakarta. The Honorable Mr. Baikuni, Doctor of Philosophy, President of Indonesia Public Health Association, Jakarta Region. All speakers, Mr. Dr. Safiu Buyen, Doctor of Philosophy, Master of Business Administration, Bachelor of Medicine, and Bachelor of Surgery, Master of Public Health, FRSPH, from University of Toronto, Institute Pandemic, Canada. Mr. Calvin de los Reyes, Doctor of Philosophy, from University of Philippines, Manila, and University of the Ryukyu, Japan. Mr. Febi Dwi Rahmadi, Bachelor of Public Health, Master of Science, a Doctor of Philosophy from Griffith University, Australia. Mr. Dr. Abu A'la Al-Maududi, Pulmonology Specialist from Faculty of Public Health, University of Muhammadiyah, Jakarta. Dr. Muhammad Fakhri, Pulmonology Specialist from Faculty of Medicine and Health, University of Muhammadiyah, Jakarta. Mr. Dr. Rizky Akaputra, Pulmonology Specialist from Faculty of Medicine and Health, University of Muhammadiyah, Jakarta. The Honorable Moderators, Mrs. Naria Mutila Nasir, Bachelor and Master of Public Health, Doctor of Philosophy, and Mrs. Munaya Fauzia, Bachelor and Master of Public Health. Honorable colleagues, ladies and gentlemen. Ladies and gentlemen, in this opportunity, allow me to welcome all of this conference participants by thanking and praising to the Almighty God for all His blessing, grace, and mercies that have led us gather in this room in excellent condition and health. Dear speakers, distinguished guests and participants of the first Muhammadiyah International Public Health and Medicine Conference by topic Management for Tuberculosis Control during COVID-19 Pandemic. Faculty of Health, University of Muhammadiyah, Jakarta, in collaborating with Faculty of Medicine and Health, University of Muhammadiyah, Jakarta, and Indonesia Public Health Association, Jakarta Region. I'm very pleased to be the host in this virtual conference. Good morning and welcome. Ladies and gentlemen, tuberculosis continues to be the biggest infectious disease killer on a global scale. accounting for 1.4 million fatalities in 2019. These precarious conditions may be further aggravated by the COVID-19 pandemic and associated action. Glacius modeling study issues a stern warning that a reduction in tuberculosis case detection, which was induced by COVID-19 in 2020, could result in major rise in tuberculosis deaths, bringing us back to the level of tuberculosis mortality in 2015. As the world mobilized to tackle the COVID-19 pandemic, it is critical to guarantee that critical services and operation for addressing long-standing health problems continue to protect people living with tuberculosis and other diseases or health condition. Health services, especially National Tuberculosis Program, must take a proactive role in ensuring an effective and timely response to COVID-19. Ladies and gentlemen, the conference like this can provide a valuable opportunity for research scientists, industry specialists, and decision makers to share the experience. I'm grateful to the experts who have come to share their knowledge in this conference. I also welcome the representative of government, industrial associations, and NGO who join us. I'm sure you will have fruitful and rewarding changes both today and tomorrow. I hope we get success in this important conference, and I look forward to learning about the outcome. Thank you. Wabillahi taufiq wal hidayah. Fastabiqul khairat. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you for our Mrs. Dr. Andriani, Master of Public Health, for the speech.
And for the last speech is from President of Indonesia Public Health Association, Jakarta Region. For our Mr. Bakuni, Bachelor, Master, and Doctor of Philosophy of Public Health, time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirrahmanirrahim. Wassalatu wassalamu ala ashrafil anbiya wal mursalin wa ala alihi wa sahbihi ajma'in. Honorable Rector, University of Muhammadiyah, Jakarta. Honorable Deans and Vice Deans at University of Muhammadiyah, Jakarta. Honorable IAKMI, Jakarta Expert Council. Honorable Speakers, Mr. Dr. Safiuddin Buyan, Mr. Kelvin, Mr. Dr. Abu A'la, Mr. Dr. Muhammad Fakhri, Mr. Dr. Rizki, and Mr. Febi Dwi Rahmadi, PhD, and also all of distinguished guests. Firstly, I really salute the extraordinary cooperation between friends at Muhammadiyah and IAKMI Jakarta in realizing this event. Dear attendants, we make this event as a meeting place between experts to discuss and find solutions on how we deal with these public health issues, especially in management for tuberculosis control during COVID-19 pandemic, because almost all current health activities and programs can be said to be neglected because the whole country is focused on the high death rate due to COVID-19 in Indonesia. Basically, we IAKMI Jakarta really support mutually beneficial cooperation with any party in making scientific events like this to find the best solution to face the pandemic engulfing our country and the world. Ladies and gentlemen, one thing that I always emphasize in taking a health approach is how to educate the upstream side namely the preventive side. I hope the scientific event can bring a public health approach that is more deeply rooted in community so that the contribution made can be felt by the wider people. Those are the few opening words that I convey. Hopefully, this event can be useful for the nations and the world. Thank you for your attention. Assalamualaikum warahmatullahi wabarakatuh.
Wabarakatuh.
Thank you for our Mr. Bekeni, Bachelor, Master, and Doctor of Public Health, Doctor of Philosophy of Public Health for the speech.
For the sixth agenda is the main event, the presentation of conference material, discussion, question, and answer, which will be divided into two sessions. Allow me to read the CV from our moderator, which will be guided in the first session. Ms. Narila Mutia Nasir, Bachelor, Master, and Doctor of Philosophy of Public Health from Education, Doctoral Graduate School of Human Sciences, Osaka University, Japan. Bachelor and Master of Public Health in University of Indonesia. From work experience, Senior Lecturer, Faculty of Health Sciences at University Islamic Syarif Hidayatullah, Jakarta, 2018 until now. Research Fellow, Postdoctoral in Osaka University, Japan, 2014 until 2017. Furthermore, she has a 19 journal publication, 23 scientific presentations, then has obtained a research experience. And she is active in several organizations, one of which is IACMI as Secretary General in 2020. For Ms. Narila Mutia Nasir, Bachelor, Master, and Doctor of Philosophy, time is yours. Thank you.
Thank you, Karima and Dinda. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, we proudly welcoming you to the first Muhammadiyah International Public Health and Medicine Conference 2020, held by the Faculty of Public Health and Faculty of Medicine and Health Sciences, University of Muhammadiyah, Jakarta, and collaboration with the Indonesian Public Health Association, Jakarta Region. The Honorable Rector, University of Muhammadiyah, Jakarta, the Honorable Deans and Vice Dean at the University of Muhammadiyah, Jakarta, the President of Indonesian Public Health Association, Jakarta Region, the Honorable Speakers, and all the participants. Thank you for joining in this conference. Please allow me, Narila Mutia Nasir, to lead this session as your moderator. Our conference theme is Management of Tuberculosis Control during COVID-19 Pandemic. As we know that COVID-19 pandemic is not yet coming to the end. All countries are struggling to handle the situation. The current data from WHO shows that the confirmed cases are more than 194 million in the world, with more than 4 million deaths, unfortunately, including one of our conference committee, Nazarwin Saputra. In his young age, his struggle against COVID-19 was stopped last June, and we lost him. So please send your best prayer to him. We all know that this COVID-19 pandemic has the impact to many things, including to the other infectious diseases such as tuberculosis. Before pandemic, TB is one of the main health problems in Indonesia. We have challenged to reduce the high number of TB cases, and it becomes more complicated since COVID-19 pandemic. So actually, what is our challenge to manage TB control during this pandemic? Let's find the answer through the sharing knowledge from the three great speakers today. We have Dr. Shafiullah Buyan, PhD from University of Toronto in Institute for Pandemic Canada. Hello, Dr. Shafi. Assalamualaikum. Already here, Dr. Shafi?
Yes, Assalamualaikum.
Waalaikumsalam. Hello, Dr. Safi. Thank you. We
Yes.
also have Dr. Calvin de los Reyes from University of Philippines, Manila, and University of Ryukyu, Japan. Hello, Dr. Calvin.
Good morning, everyone. Nice to meet
Morning.
you, Tia, again, and Dr.
Yeah.
Shafi.
And we have Dr. Abdul A'la Al-Maudidi from Faculty of Public Health, University of Muhammadiyah, Jakarta, Indonesia. Assalamualaikum, Dr. Abdul A'la. Okay, Dr. Abdul A'la is already here also, I think. So, let's start with our first speaker, Dr. Safiullah Buyan. Dr. Buyan is one award-winning faculty member and an international recognized academic professional leader in the global health training, research, and education initiatives with diverse experience in both developed and developing countries. He finished medical college at Dhaka, Bangladesh, and then he worked as the founding license of Maternal and Child Health Research and Training Institute in Bangladesh, where he focused on capacity building training of health professionals. After his completion his PhD in Human Science, Osaka University, Japan, he worked as the SPS postdoctoral at the same university. And in 2010, Dr. Buyan emigrated to Canada and began a new career focused on how equity-informed approaches can improve health service and healthcare training. Today, he is a faculty member both at the Dalla Lana School of Public Health, University of Toronto, and Ryerson University. Besides academic activities, he also active in humanitarian services. Dr. Buyan currently interim board of directors, Canadian Association for Global Health, and outgoing chairs, board of directors, Canadian Coalition for Global Health Research. It's a great opportunity to having you, Dr. Safi. Thank you. Dr. Safi will have a presentation about global health challenges regarding TB management during COVID-19. Please, Dr. Safi, time is yours.
Wow, thank you. Thank you, Dr. Narila Motia. And I hope all you are hearing me properly.
Yeah, we
Excellent.
can.
So Honorable Rector, Dr. Mamunur Murad, Dean, respected Dean, Vice Dean, my favorite Dr. Bai Kuni, the leader of public health, my beloved Dr. Narila Motia Nasir, and my most favorite Filipino scholar, Dr. Kelvin de los Reyes, and my other colleagues from around the world, speakers and fellow faculty members and young public health professionals. Assalamu alaikum and good morning for Indonesian, maybe good evening from Toronto. It's almost 11, so we are a little bit 20 minutes ahead of schedule. That's why I may have a little bit time to exchange my views. Thank you, Narila, to remind me to join earlier, even though I was not prepared because I was outside for walking, evening exercise. You know, COVID give us opportunity to take care of yourself. COVID give us opportunity to learn new things, new skill. That's why I don't blame COVID actually. This is a distinct pleasure, as we know all that Albert Einstein said, in the middle of any crisis, opportunity lies. If it is not COVID, maybe I cannot take flight to go to Indonesia to meet you. But due to COVID, and I can see all my colleagues and beloved people in one single frame. So it's actually a blessing from the God. So we have to accept what happened. So again, I'm thrilled to meet with 225 people. The public health future of the world give us opportunity to share our ideas. I thank God, and I really excited. We have a lot of story, right, Dr. Narila? And we have a lot of good positive story. We studied together with Agustin Kutsumayati, my friends, and Baikuni, and we have a big team for we call international collaboration team. Still 20 years almost we are together and learning together, growing together. Again, my profound thanks to Muhammadiyah University to invite me, and special thanks to Narila that she organized so nicely, and which really impressed me. That's why I cannot say no, even though it's midnight, and I really feel honored, thrilled, and excited. And let's go to my presentation. As you know, our rector rightly mentioned, and someone mentioned, the conference is one of the things we can share our ideas and exchange our views and learn from each other. Most importantly, I think this is one of the celebratory events for the professionals. What we do, and we can see our friends, our colleagues. That's actually impressed me much more, because we all know all these things fact and feature. It's nothing new, but it's the occasion we can exchange. So that's why I'm again thankful to Muhammadiyah International University or Public Health Medicine Conference to arrange this kind of novel initiative. I hope everything will be excellent, because when it started good, it will finish. So congratulations in advance. So Narila, I should share my screen, or?
Bella, can you help to share Dr. Sapi PPT slides?
I can do it by myself?
You also can do it by yourself, I think.
Okay, so whatever. So let me open my file.
So it's okay? Can you share the screen?
Just 1 second. I'm just looking my file. Okay. I have the privilege to share my screen, right?
Okay, I think you can, yeah.
Excellent, excellent. So that is great. So as we know, very interesting that coronavirus disease has emerged as a serious health threat in the global area, right? So all over the world, it's just giving us an extra burden to think about differently in healthcare system, and is really the disease our global economy, they infringe on individual freedom and taken the unprecedented toll on healthcare worldwide. And TB disease is not known to put people at high risk of COVID-19 infection, but it may put you at risk of having more severe symptoms. That is the relationship between COVID and tuberculosis. And you can see very high overview fact about the TB, which is widely known to you. There is some fact to know that TB, while facing the COVID, how it is impacted in our healthcare system locally and globally. So every 22 seconds, someone is dying. When we're talking, you see how many hundreds of people will be dying whole day. So healthcare cost also getting higher and higher. And most importantly, the future generation, the child, they are going to lose their life. So almost 1.2 million children get sick of the tuberculosis, which is alarming. So we need to think about it. The World Health Organization, this slide easily is showing you the two-thirds of the total cause, the disease burden is this country, India, Indonesia, China, the Philippines, Pakistan, Nigeria, Bangladesh, and the World Health Organization on 17 June 2021, released update the global list of high burden countries for tuberculosis, HIV associated with TB, and multi-drug resistant TB. The new list are for 21 to 2025, and this replaced those previous lists 2016 to 2020. So most importantly, you can see the most three high contributing countries, India, China, and Russia. So thanks God, Indonesia is not in the list. In the top three is a good thing. And if we think more holistically, tuberculosis and COVID-19 are both infectious, right? And that attack primarily the lungs. The source is the same place. They all attack the same place, two enemy attacking the same. However, TB has a long incubation period with a slower onset. That is the difference. Past 12 months, we have pushed back global tuberculosis by 12 years. So it's serious. Even though 12 or 14 months, it means each month COVID with us, our tuberculosis treatment or success achievement will be delayed or pushed back a year. So that is very alarming. Getting very, very bigger and bigger. Instead of 332 million is going to billions of dollars funding estimated to combat the TB disease. So if we think about the COVID as an enormous impact on health system, we all know health system is everywhere in the world, not in Canada, not in Australia, not in Japan, not in Indonesia, not in Bangladesh or Philippines. Everywhere there is a huge impact happen due to COVID. COVID is this impact. You can see this slide from the Global Fund implementing countries, that how much 70% of healthcare workers reported that decreased number of people coming to the health facility for TB for a valid reason, right? We are talking about stay home, use mask, don't go out. So people are scared, so they cannot go. Globally, 50% healthcare work reported that healthcare facility decreased TB service because there is no provider. Provider is somewhere assigned for other things. So this is one of the examples. 88% drop in for TB notification. They have no notice. So come to the clinic, take your medication or so on, nothing. So 69% healthcare worker lacking of PPE. So we are lucky that we are in Canada. Everybody is getting what they need. Government support or international collaboration is well play positions, but many countries, they have a problem with this logistics, which is not new. So this is the situation we are facing globally. And I think Indonesia also does very good experience as what I am talking about is evident that 73% people with TB facing challenges accessing the treatment. So you can see 3/4 of the population of the TB is not getting addressed what they need. These are serious consequences. People working with the TB field are seeking significant interruption and direction in the work and research towards COVID-19. Globally, researchers report 73% employees reassigned to work with COVID-related projects because they are known to be expert in respiratory disease. So they are diverted to the COVID clinics or somewhere rather than they concentrate their TB services. And 59% GFIC TB policies and programs officer reported they also reassigned. And 57% also lacking necessary resources for TB research, they noted. 81% says delayed of TB research in the field studies and so on. So you can see all are 60% to 75% is 2/3 to 3/4 is just somehow obstructed by the COVID. So here's some best practice which can be implemented in future, all as well as some are already exist in the system. So we learn from the COVID not only experience of our sufferings, but also we have a sub-innovation, how we can be people-centric, because community-based and community-led response is very important. And the COVID shows us this example. And also universal health cover is one of the examples that people can take advantage of. So it's difficult to make out-of-the-pocket payments for all the services. As you know, COVID is an example, government and international agency coming forward to minimize the out-of-the-pocket services in the healthcare. And also, this is the time to stop TB stigma together. Because, you know, the COVID also when it started, it was stigmatized. Those who have a COVID, their house was red flag. And now people understand this is not their fault. And same thing, TB is not their fault. HIV is not the patient's fault. It is the virus who is our enemy, not the people. So that is another issue. And prevention and infection control is very important, both TB and COVID-19. And you know that we all have mobile phone, we all have a smartphone or chatbot or very high-tech things. So we can take this advantage in TB disease treatment and TB control and TB eradicate. Basic infection prevention control and this technique we can easily share through the smartphone, through the app. And you know, globally, many countries in G8 or other OECD countries, they have all apps. Right away, I can open my cell phone and I can see where's the COVID services near to my house, 1 kilometer, 5 kilometer, 10 kilometer, all is possible. Similarly, we can integrate this COVID experience, shift it to the TB experience, how we can share information. There should be no doubt about the misinformation. We should be giving the right information. We should educate the community. We should have a right referral system, and we should have a contact tracing and so on. And also, regular supply chain should be continued, cost-free TB drugs through improved procurement and distribution strategy to the client's doorstep. So it is important because without full coverage, you cannot end the control. You cannot end the TB disease. And you know that today I was talking about some of the experts in HIV. They're talking about the vending machine. They're talking about the invention of new business company who sell the HIV stool kits, and you can get it in from the roadside, and you can go home and you can test your HIV. And then this technology can be spread out around the world. That's why Canada-based company, they're coming forward. They realize that laboratory and the health facility is now already overcrowded, so many things. And also laboratory is sometimes people stigmatize, and laboratory is not fully ready to address this kind of HIV people. That's why they're thinking it should be just you go and buy and find the ATM vending machine, and then you get the kits and go like a pregnancy test, like a COVID-19 test. So this is one of the hope and aspiration. The COVID, we are giving a quick rapid test, same thing. We don't need to go to clinic. We can do it our doorstep in community level or in the household level. So this is one of the innovation in terms of how to obtain and detect the COVID, TB, and then pathogens, so that we can decentralize the testing approach similar to the COVID experience. This is actually huge. So that's why I said in the beginning, COVID is all not bad. Some experience we learn, we should have never have this chance to learn this. And TB treatment, and we have a lot of opportunity to shorten the TB regime because there is so much drug available in the market. We can easily, you know, previously it was 9 months, 7 months, and 2.5 months, 3 months. So we can work on it, and we can have a very good virtual consultation, so that it will increase the adherence support, including video observatory therapy, so they can nurse, midwife, nurse and practitioner, they can or organize this kind of thing. So the hospital or health center will be less burdened. TB also, many drug is on the pipeline, so it's coming. So which is the good news. So I think TB treatment will be revolutionary, followed by the COVID-19 treatment experience. And we know the this is the digital one world. So everything is under mode of digitalization. So we can treat real time, we can collect real time data, we can use artificial intelligence, which is very much popular in G8 countries. So we can use mobile phone and other software easily nearby, so that you can click this at Indonesia and we can see in the lab in the real time in Canada. So we can make a decision of your treatment or complexity, whatever it is. So it's easy to use the portable digital technology and upload this data in real time. Any developed country and scientist or research lab in collaboration with the local lab, they can see and give you good suggestions so that treatment will be quality and world class. Of course, someone is saying in the opening speech that we need to be proactive. This is very important term. So in many nations, they just reactive. Many diseases, we just reactive. As we go, we just change. But now, COVID give us the opportunity to think and rethink that we need to be proactive, how we can learn the COVID experience and to convert our learning process so that we can act before the things are going in a bad shape. The treatment, diagnosis, procurement, supply, all can be digitalized or can be planned well ahead of time before we are in a crisis, because it's important. And also the communication and the transparency, cooperation between parties or sectors need to be addressed. Knowledge and experience sharing under leveraging capacity is one of the most important best practice. Finally, I would like to say that we should drastically increase and sustain investment in health system. COVID shows us around the world that how much fragmented our health system is, and our efficiency needs to be improved. We need to continue to inform, advocate, and empower local communities, and to lobby government, policymaker to ensure that tuberculosis as well as COVID-19 remain high on the global agenda. These two pandemics, one is old, another is new, remained as of the need to be proactive and long-sighted. We need a visionary ethical leadership in the health system to plan ahead, not to become complacent. I thank you all for your patience and time. I'll be happy to give you any clarification or question you may have. Thank you so much.
Thank you, Dr. Shafi. Actually, it's like from your presentation.
It was timely, or I took
yeah.
so much time?
No, it's okay. I can see that actually COVID-19 pandemic is like also we can find blessing in disguise, right? Not only the negative things, but we can take the positive things about this pandemic. Thank you for your presentation. I'm sure that actually the audience wants to ask many things, but I'm trying to have like the panel for the speakers, and then we have more time for discussion later. So I hope even it's night there, please stay tuned for our session. Thank you very much. And for the audience, if you want to ask to Dr. Shafi, please prepare your question. You can write down on the chat or later you can ask directly. So you can write down in Bahasa also if you want. And then we will have the Q&A answer after the third speaker. Thank you, Dr. Shafi. Now we move to the second speaker, Dr. Calvin de los Reyes. Yeah. And also for the participant, don't forget to fill in the link of attendees. Yeah. So Dr. Calvin de los Reyes. Dr. Calvin completed his bachelor in the University of Philippines and finished his master and doctoral degree at Osaka University, Japan. He also received many fellowships from USA and UK. Now he is an associate professor in the University of Philippines, Manila. So actually, he has a lot of experience, but not all he write down on his CV. So it's an honor to have you as speaker here, Dr. Calvin. Thank you.
Thank you very much, Tia.
And we will learn from Dr. Calvin about TB control program in the Philippines amid the COVID-19 pandemic. So time is yours, Dr. Calvin.
Okay, thank you very much, my good friend, Dr. Narila Mutia Nasir. Let me share my slide. Okay. Mhm. Yeah. Okay, for a while. Can you see my slide now better?
Yeah, we can see it.
Okay, thank you very much. I'm very honored to be part of the first Muhammadiyah International Public Health and Medicine Conference. I congratulate the Faculty of Public Health, the University of Muhammadiyah, Jakarta, in collaboration with the Faculty of Medicine and Health University of Muhammadiyah, Jakarta, and the Indonesia Public Health Association, Jakarta region. Similar to Dr. Shafi, a very good friend from Osaka University, I'm glad to be here and in support of Dr. Tia and also Dr. Baikuni. And I thank everyone, and I do hope that you will have the patience of bearing with me in the next 20 minutes of my presentation. The presentation of Dr. Shafi earlier posed more issues and concerns, and at the same time addresses TB control in a global scale. I am asked by the organizers to present about TB control program in the Philippines in time of COVID-19 pandemic. I am aware that most of you are also familiar of your corresponding or in your country in Indonesia of the TB control program. I won't say that what's happening in the Philippines is actually unique or any different. I suppose or I assume that it's quite similar. So perhaps after my presentation, it would be nice to actually exchange ideas or perhaps look into the similarities of and also some challenges that we might be able to address together through this webinar conference. Okay. As you can see here in my slide, the United Nations Sustainable Development Goals include ending the TB pandemic by 2030, and it's goal number 3. The strategy is provide a unified response to ending TB deaths, disease, and suffering, builds on 3 strategic pillars underpinned by 4 key principles. When I was preparing this this presentation, I had the help, and I have to recognize representatives from the Department of Health, Ms. Roja Estrelita Salvador, Dr. Alan Fabella, Dr. Mary Rose Santiago, Dr. Leia Mayra de Mesa, and Ms. Gelisa D. Reside. So whatever I'm going to present today is a collaboration among these individuals, and I am but a messenger, so to speak, to represent about the TB control program in our country today. So moving on. There you go. Significant strides have been accomplished in the country towards reducing TB burden. In support of the Millennium Development Goals, 3 impact targets were adopted by the Stop TB strategy to monitor the progress of implementation. In the Philippines, as one of the member states of the United Nations, we adopted the impact indicators of PhilPact. These targets are decreasing the trend of TB incidence and reducing by half the TB mortality and prevalence rates against the 1990 baseline data. And fortunately, by the end of 2015, as you can see here on the table below, based on the 2016 Global TB Report of the WHO, the Philippines is one of the 9 high TB burden countries that have reached the Millennium Development Goals or MDGs. This is based on the WHO estimate prior to the 2016 NTPs. I should mention that the Department of Health has its National Tuberculosis Control Program with a long-term goal of reducing TB burden by decreasing TB mortality by 95% and TB incidence by 90%. By 2022, by next year, we want to reduce TB burden by decreasing the number of TB deaths by 50% from 22,000 to 11,000 and decreasing TB incidence rate by 15% from 554 per 100,000 to 470 per 100,000. We also want to reduce catastrophic costs incurred by TB-affected households from 35% to zero, and at least 90% of patients are satisfied with the services of the DOTS facilities. So even with this first slide of mine, no, you would notice that, with our mid-term goal of 2022, how are we supposed to meet these goals? No, and how are we going to catch up with this challenge? Especially since we are under the pandemic. I'm going to give you a brief highlight of TB in the Philippines. And among the 30 high TB burden countries, the Philippines actually ranks 4th. And among the high multi-drug resistant burden countries, the Philippines actually ranks 7th. In 2019, there were an estimated 599,000 TB cases in the country, with 554 cases per 100,000 people, according to the WHO report. Approximately 74 Filipinos die of TB every day and is among the top 10 causes of death in our country. With the introduction of mandatory private sector case notification, the Philippines have recorded a 29% increase in case notification since 2017. While this is a significant progress, an estimated 190,000 TB cases are still missing, which means they were either not diagnosed or diagnosed but not notified. For rifampicin-resistant TB and MDR TB, multi-drug resistant TB, the gap in cases notified is even greater. And this is in 2019. So what are we going to expect in 2021? In the Philippines, community quarantine began in March of 2020, last year, and subsequently was implemented in most parts of the country. Consequently, active TB case finding was discontinued. Visits of symptomatic individuals to health facilities was restricted. Priority of health services was shifted to COVID-19. Gene expert platforms in selected TB culture laboratories were instead assigned to COVID-19 screening, and TB contact tracing was limited. From January to March this year, the National TB Control Program at the DOH recorded a total of 89,000 new and relapsed TB cases, declining steeply by almost 20% between February and March. So the scenario is not really very good. And here, I want to present the COVID-19 disruption on our TB elimination efforts. And we are familiar with the cascade of care, which is screening, testing and diagnosing, treatment, and prevention. So for screening, of course, there are no active case findings, because of the restriction of movement for consultation and limited services available because the priority was COVID and no PPEs were available. The same goes with testing and diagnosis, where testing is stopped while there is no PPE. Of course, because of the lockdown, there are restrictions of specimen transport. And the TB expert, as mentioned earlier, were displaced by COVID tests. Most of the staff were focusing on COVID-19 efforts. For treatment, again, because of the restricted movement for clinical visits, lab closed or no transport for follow-up laboratories, and TBC displaced by COVID testing, and again, the question of limited staff. And finally, on prevention, contact tracing limited by quarantine and access to care are limited with closed or no transport at all. So based on actual data in 2018, 2019, and the first quarter of 2020 accomplishment, there's actually a drop of 25% during the lockdown, drop of 15% during the 6-month restoration period, that's the third quarter and the fourth quarter of 2020, However, there is some increase, 20% increase in 2021 when we tried reopening our communities. There you go. And again, the question is, with this current scenario that we have when it comes to drop in TB notification, how are we going to actually meet the 2022 medium-term goals? Thus, we developed, together with the help of our several stakeholders, international aid agencies, the National TB Program Adaptive Plan. This is the feasible measure and adjustment to current implementation TB care guidelines and complement the COVID-19 response of the designated facilities and providers. The National TB Program Adaptive Plan is a reference in updating relevant NTP document and guidelines and was developed to issue clear guidance to TB providing facilities on how to continue their TB services along the TB cascade of care. So the need to develop an adaptive plan is not just for the NTP, but for all sectors, health and non-health. An initial guidance has been issued by the IATF, led by the NEDA, or the National Economic Development Agency, for planning the new normal. Specific for health, the IATF issued Resolution Number 28, which mandated the Department of Health to develop the minimum public health standards to mitigate COVID that will be implemented by all sectors. There. So what happened was that from April, we have developed the outline of this plan, the NAP, and further in May, creation of the task force, and in June, we tried to finalize the NAP. And what you can see here is actually the final version. So let me present to you the NAP's general guidelines. And there are 5 facets. We observe the minimum public health standards. We continue screening of presumptive TB. We implement TB safety and ITC measures, flexible treatment management and provision of anti-TB meds, and the use of digital technology. And actually, a number of these were already mentioned broadly by Dr. Shafi earlier. So for the observation of minimum public health standards, all facilities and providers involved in TB care shall observe the minimum public health standards to mitigate measures for COVID-19 response across all settings, such as home, public places, offices, and workplaces, prisons, and other places of detention, health facilities, among others. When we talk about continuous screening of presumptive TB, this could be through positive, active, intensified, and enhanced case finding, shall continue subject to mandated physical distancing and strict infection control measures. In implementing TB, biosafety, and ITC measures, all staff working in TB laboratories and healthcare facilities shall implement TB safety and infection prevention and control measures. TB diagnostic testing shall continue with strict compliance to standard precautions for infection prevention and control and laboratory biosafety standards. For the flexible treatment and management of provision of anti-TB meds, healthcare facilities at all levels rendering TB services shall implement a flexible treatment management and provision of anti-TB medicines to enroll TB patients. This is to decongest and minimize physical contact from frequent visits to the health facility. Monitoring of compliance and adherence to treatment may be via treatment supporters such as family members or carers, digital adherence technologies or DATs, such as texting, telephoning, video observed treatment, whichever is available and most accessible and feasible to the patient. And then finally, the use of digital technology, such for TB service delivery, such as adherence monitoring and TB screening through virtual consultation, contact tracing, and adverse event monitoring, and other programmatic purposes. Other purposes such as electronic recording, e-learning, and laboratory information systems are highly encouraged for health workers and persons with TB alike to have early case detection, early treatment initiation, which help complete treatment and promptly manage adverse drug reactions and treatment success. So, there's the specific guidelines, of course, that that is according to the TB cascade of care. So we have screening, We tried to develop customized various safe approaches for TB screening or case finding based on the community quarantine status in different locations to ensure continuation of TB screening and case findings. We have treatment or treat. Patient-centered outpatient and community-based care should be strongly supported and preferred over hospital or facility-based treatment for patients unless there's a serious condition where the patient is required for hospitalization to reduce risk of transmission. And also prevention, TB preventive treatment should continue and be prioritized during this time. The country is currently at 5% coverage for contacts of bacteriologically confirmed TB patients, 9% in children less than 5 years old who were household contacts, and 52% in people living with HIV. The country cannot afford to further decrease TPT since a high TPT coverage is one of the key interventions necessary to substantially reduce TB incidence. And then finally, investment requirements and other cross-cutting concerns. It takes into account the adjustments in the resources needed to sustain provision of TB care across cutting concerns. There you go. Let me go through them specifically. I believe I still have 5 minutes, Tia, right? First is the rationale for screening. There's a need to develop customized various safe approaches for TB screening amidst COVID-19 risk to ensure continuation of TB screening and case finding. So perhaps the best that I could give you are examples instead of this. No, we want to simultaneously screen COVID-19 and TB. No, and we want to implement ITC measures, physical distancing, use of appropriate personal protective equipment, hand hygiene among patients and their companions and health workers. Specific guidelines among high risk groups when we do the screening. Also use of infographics, etc. And I guess for the details of this, I would be sharing the slides to all of you. I wanted to highlight the experiences in Central Luzon. So what they did was they have close coordination with the specific tertiary hospital and making it as a COVID-19 referral center. And they have included a COVID TB caravan in every barangays. And when we talk about the barangay, it's like a posyandu or the smallest unit in Indonesia, if I'm not mistaken, or cadre. No, I might be wrong. But what they did was they had this laboratory vehicles, no, instead coming to several of the barangays, the smallest units of villages in the country, to actually screen patients. No, there you go. The second part is testing and diagnosing. So as mentioned, accurate diagnostic are essential for both TB and COVID-19 patients. And we have the TB diagnostic testing with expert MDT, rifampicin as a primary test, and shall continue with strict compliance to standard precautions for infection control, infection prevention and control, and laboratory biosafety standards. No, there, and at times instead of having the sputum test done in the facility, the sputum test is being done at home. No, there you go. There are specific guidelines that I won't go through on the adaptive changes, but I wanted to share is that in yes, again, we had the sputum test riders who actually post their who actually goes to the households to collect the specimen and are readily transported to the regional epidemiological surveillance unit for testing. Also, they conduct the DTRL or the diagnostic laboratories, no, are also capable of both testing confirmed COVID-19 and presumptive TB patients, and expert results released within 1 day. There you go. And similarly, the local government unit provides vehicles similar to what I've shown earlier for identified clients for chest X-ray. And there you go. That's one of the better examples. Okay. For treatment, patient-centered outpatient and community-based care should be strongly supported and preferred over hospital or facility-based treatment for patients to reduce risk for TB transmission and protect patients with TB from contact tracing. So contracting COVID-19 instead. So it is with strict adherence to the provision of the SNDR TB treatment management, despite the restrictions brought by the quarantine. So we want to minimize travel and promote physical distancing by reducing clinic visits during the treatment, and strict adherence to the provision of anti-TB treatment to all diagnosed DSTB cases within 5 working days from collection of sputum and 7 days of MDR-TB. So again, I would be skipping the specific guidelines for treatment. But what is interesting is that there is a decentralization of MDR-TB clients and endorsement of second-line drugs. Instead of them coming to the facility, door-to-door delivery of anti-TB drugs by the health workers are conducted, and repacking of patients' medication to ensure constant supply. And then finally, for prevention, no, I wanted to highlight here that there's continuation to exclude active TB by symptom, and all healthcare providers shall ensure completion of preventive treatment through methods and promote physical distancing and reduce clinic visits, and as well as recalibrating a social and behavioral change communication as a cross-cutting component of the adapted plan. So there's a call of the hashtag TB-Free Philippines. So for the directions, in this adaptive plan, the communication strategy is realigned to messaging to highlight resilience. Further, including TB in community engagement portfolios of the HPCs, and talking to decision makers in media about the effects of COVID-19 on TB burden. We want to maximize high-risk perception of transmission and addressing the stigma, which was earlier mentioned, and discrimination. And we harness digital technologies for information delivery. So even with prevention, we maintain the provision of PPEs to the rapid diagnostic laboratories for TB testing to continue. We return demonstration of TB 101 lectures. And there, of course, there are IEC materials, specific in certain dialect or language, ensuring that, of course, the safety of healthcare workers during screening amidst COVID-19. Also, I should include that there are reporting and recording and reporting systems, the IDOTS volunteer doing chart review of eligible cases for contact investigation, and ensuring continuation and validating reports in hospitals. And of course, what I wanted to highlight with cross-cutting is that we continue monitoring and recertification despite the MGCQ. And most of the LGUs, some of the LGUs have already allotted budget for TB procurement of TB drugs and commodities. We conduct teleconference similar to this to disseminate regional memorandum, even national memoranda, and conduct national TB program activities through virtual platforms. So you can see that the digital or technology is actually helping out in the process. I want to sum up everything. I've mentioned a lot, we want to ensure the continuity of TB services, and the program issued the memorandum that even a 1-month supply of drugs should be given to the patient. And new standards will be issued through the National TB Program Adaptive Plan. Screening for TB was subjected to mandated social distancing and infection control procedures, and algorithm of handling specimens for TB testing in the community with ongoing transmission of COVID-19 was developed. Home-based TB treatment by using digital adherence technologies has been introduced. So while COVID-19 has imposed great challenges to national TB programs, it has also created opportunities to develop innovative strategies to ensure continuity of TB services and ultimately to strengthen TB care, prevention, and control. What we have learned is that most of this facility-based services are already coming closer to our target population. And it took COVID-19 to make us realize that it could be done. As mentioned by Dr. Shafi and broadly earlier, as quoted by Winston Churchill, never let a good crisis go to waste. And I think these are a multitude of learnings that I wanted to share from the Philippines, and hopefully later on I would also be learning from all of you. With that, I end my presentation. Terima kasih. Thank you. Maraming salamat po.
Maraming salamat po. Thank you, Dr. Calvin. Thank you very much for your nice presentation. I think we learned a lot from the Philippines, that what Dr. Safi already mentioned about global health challenge, and the Philippines has tried to answer that through the digital technologies, using the digital technologies, and also from the simultaneous screening for TB and COVID in one time. That's very good. Again, for the participant, take a notes for the question for Dr. Calvin in the chat room. I already have two for Dr. Shafi next. And don't forget to fill the attendee link. And now, thank you, Dr. Calvin, because you want to move to next speaker. We have Dr. Abdul Alam Al-Maududi. Yeah.
Okay.
Okay, yeah, Dr. Abdul Al-Maududi finished his doctoral degree from two universities, State Islamic University Jakarta and University of Ibnu Khaldun Jakarta, both with the predicate cum laude. Okay, that's really good, right? He is a pulmonologist, and beside his activities as lecturer and medical doctor in the referral hospital for COVID-19, he has a lot of activities in the community. He also founder for School for Hafiz, memorizing Al-Quran. Dr. Abdul A'la also active in organizations such as Pulmonologist Association and Indonesia Medical Association. And the important thing, he also a certified Hafiz Quran for 30 juz. Oh my God, Masya Allah. It's a great combination, science and religion, right? So we are so lucky to have Dr. Abdul A'la as our speaker here. He will explain about TB and COVID-19 pandemic, especially maybe in Indonesia. So please, Dr. Abdul A'la, time is yours.
Okay. Thank you, moderator. Okay. Okay. Can you see my slide?
Yeah.
Okay.
We can see the slide.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you for the opportunity. Thanks to Dr. University of Muhammadiyah, Jakarta. Thanks to Dr. Andriani as Dean of Faculty of Public Health, University of Muhammadiyah, Jakarta. And to Dr. Baikuni Berman as President of Indonesia Public Health Association, Jakarta Region. And dear Honorable Mr. Dr. Sofi Ubihan and Mr. Calvin de los Reyes, welcome to the first Muhammadiyah International Public Health and Medicine Conference. And thanks to all of participants. Today, I would like to present my presentation with the title is TB, tuberculosis, and pandemic COVID-19. Okay, this is my outline, consists of introduction, causes, COVID-19, and impact of the COVID-19 pandemic on TB management, and the last is conclusion. Okay. Introduction. We know as the world comes together to tackle the COVID-19 pandemic, it is important to ensure that essential service on operation for dealing with a long-standing program continue to protect the lives of people with TB and other disease or health condition. On 31 December 2020, China first reported a group of cases with atypical pneumonia syndrome, coronavirus 2. And on March 11, WHO declared COVID-19 as a global pandemic. In July 26, 2021, coronavirus case more than 194 million, and deaths more than 4.1 million in the world. In Indonesia, coronavirus case until now more than 3.2 million, and deaths more than 88,000. COVID-19 is we know 220 countries and territories, and the COVID-19 pandemic pose dramatic challenges to the capacity of the global healthcare system. Okay, this is cumulative case by days since 100 confirmed case by day in Indonesia until 27 July 27, 2021. The starting point for this chart is the on which 100 case was confirmed in Indonesia, with the trend lines following the number of days since that event from March until July 27. And this is track how the COVID-19 is spreading around the global with up to date visual that give context to the data collected on Johns Hopkins University COVID-19 map. And we know about TB, tuberculosis is one of the top causes of that globally. And since 2015, tuberculosis the most frequent cause of death due to an infectious etiology. And we know tuberculosis is a major killer, causing approximately 1.4 million deaths worldwide annually, making it second only to COVID-19 as the biggest cause of infectious disease death in 2020. COVID-19 has challenged health system and restricted essential health service delivery and health system infrastructure, from diagnostic tools to the workforce, has pivoted towards COVID-19 and away from combating illnesses, including tuberculosis. The secondary effect of the COVID-19 pandemic, including lockdown, economic turmoil, healthcare worker illness and attrition, overwhelm health facilities and fear of healthcare facilities might affect delivery of health service. Difficulty assessing healthcare assistance may have delayed TB or tuberculosis diagnosis, cause increasing transmission person to person. Yeah? Tuberculosis prevalence and mortality rate are likely to increase substantially during COVID-19. COVID-19 pandemic due to the disruption of tuberculosis service, including timely diagnostic. And then tuberculosis and COVID are both infectious, but infectious disease that attack primarily the lung. Yeah? Attack primarily the lung. Tuberculosis and COVID-19 can present with similar symptoms as we know the symptoms: cough, fever, shortness of breath, headache, and chest pain, causing difficulties in the differential diagnosis. In hospital, we can difficult about and then we can make differential diagnosis of this infection. Tuberculosis, however, has a longer tuberculosis, a longer incubation period with a slower onset of disease. The COVID-19 and tuberculosis co-infection may further complicate managing of this disease, and the risk of developing severe COVID-19 is high among elderly person and in the presence of comorbidities such as diabetes, IDDM or IDDM, cancer, cardiovascular, and etc. Next, about tuberculosis. Yeah, we know about tuberculosis. Yeah, tuberculosis is a human disease caused by microbial. It may affect the lungs, making pulmonary disease the most common. And other commonly affected organ system include the respiratory system, the gastrointestinal system, the lymphatic system. Tuberculosis is the principal mode of spread is through local inhalation of infected aerosol droplets. And the symptom is chronic cough, hemoptysis, weight loss, low-grade fever, and neck sweats are some of the most common physical findings in pulmonary tuberculosis. This is the figure. There are many figures in this is chest X-ray. Showing patchy fixation on the upper right and mid-zone lung with fibrotic shadow. about hilar lymphadenopathy. And the center, this is the cavitary chest X-ray showing cavitarization on the upper left lung post primary pulmonary TB. That chest X-ray showing this opacity effusion, pleural effusion in the lower left lung of primary pulmonary TB. We can see from journal, and this is TB miliar. TB miliar, chest X-ray and CT scan. This is figure about TB miliar. Next, about major risk factors. Major risk factors for socioeconomic factors. So factors is poverty, malnutrition, wars, and immunosuppression, HIV, AIDS, chronic immunosuppressive therapy, a poorly developed immune system, and occupational, meaning construction workers, pneumoconiosis or silicosis. We can get the at Persahabatan Hospital in Jakarta, silicosis, silicotuberculosis. Okay. Next, majority of patients with a diagnosis of TB have a good outcome. A good outcome is effective treatment. But without treatment, mortality rate for tuberculosis is more than 50%. 50%. And the following group of patients more susceptible to worse outcome or death following TB infection, of early and young or MDR tuberculosis. Some of the complications associated with tuberculosis are extensive lung destruction, damage to cervical sympathetic ganglia leading to Harness syndrome, acute respiratory distress syndrome (ARDS), miliary spread, disseminated tuberculosis, including TB, meningitis, and we get the Persahabatan Hospital or referral hospital about TB meningitis, and MPM, and pneumothorax, and systemic amyloidosis. Next, about COVID-19. We know about COVID-19. COVID-19 is highly transmittable and pathogenic viral infection caused by severe acute respiratory syndrome, coronavirus 2, which caused global pandemic that led to a dramatic loss of human life worldwide. An ongoing global pandemic of viral pneumonia virus, this COVID-19, due to the virus infected million of people and remains a threat to many more. Most critically, patients have respiratory failure, coagulopathy characterized by elevation in the dimer and fibrinogen degradation product is associated with critical illness and mortality in patients with COVID-19. And all of patients get many coagulopathy. And then about etiology. COVID-19 caused by SARS-CoV-2 beta coronavirus bind to angiotensin. We know about angiotensin converting enzyme S2 receptor in nasal mucus, lung, heart, kidney, and then etc. For protein spike envelope the capsid membrane. We know, yeah, about SARS-CoV. And then pathogenesis. This is pathogenesis chronology of event during SARS-CoV-2 infection with severe acute respiratory syndrome, coronavirus 2. In fact, cell expressing the surface receptor angiotensin converting enzyme S2 and TMPRS2. The active replication and release of the virus cause the host cell to undergo apoptosis and release damage associated molecular pattern, including ATP, nucleic acid, and AC oligomer. There are recognized by neighboring epithelial cells, endothelial cells, and alveolar macrophage. triggering the generation of inflammatory cytokine and chemokine, including interleukin 6, IP10 macrophage inflammatory protein 1 alpha. This protein attract monocyte, macrophage, and cell to the site of infection, promoting for further inflammation. And then this is pathogenesis. The resulting cytokine storm circulate to other organs, leading to multi-organ damage. In addition, non-neutralizing antibody produced by B cell might enhance SARS-CoV infection through antibody-dependent enhancement. Further exacerbating organ damage, alternatively in a health immune response, and the initial inflammation attract virus-specific T cell to the site of infection. Next, about coagulopathy in COVID. Hyperinflammation in COVID-19 can cause inflammation. Some journal explain about laboratory and clinical finding of patient with COVID-19 associated coagulopathy, and prior studies of hemophilia in other viral infection and acute respiratory distress syndrome. And imbalance between coagulation and inflammation may result a hypercoagulable state. Okay, and then this is immune activation mechanism of coagulopathy in patients with coronavirus, and multiple processes may contribute to COVID-19 associated coagulopathy, including direct infection of type 2 pneumocyte and endothelial cell, leading to barrier dysfunction and increased permeability. Inflammatory response characterized by activation of T cell, neutrophil, monocyte, macrophage, and platelet, resulting in exuberant and inflammatory cytokine release, including interleukin 1, interleukin 6, interleukin 10, TNF alpha, monocyte derivative TF, and others. Next, this is typical finding. Typical finding in COVID-19 pneumonia. This A, B, C, and D. We can know and we can see about anterior posterior chest X-ray showing multiple bilateral diffuse confluent areas of consolidation with extensive involvement of blood lungs. Okay, this is from WHO clinical criteria. Clinical presentation, risk factor for severe disease is a mild disease, moderate disease. We know about moderate disease is adolescent of adult with clinical sign of pneumonia, fever, cough, dyspnea, fast breathing, but no sign of severe pneumonia, including oxygen saturation oxygen more than 90% on room air. And then severe disease and critical disease, acute respiratory distress syndrome, within 1 week of non-clinical insult or new or worsening respiratory symptoms, and chest imaging, radiograph, CT scan, lobar or lung collapse or nodules. And then critical disease, sepsis, and septic shock. Next, about therapy. We can know about therapy, update therapy.
I think we lost connection with Dr. Okay, Dr. Abu Ala is already come back. Dr. Abu Ala, can you hear us? I think this is
okay.
Please continue.
Okay, about population, non-severe, severe, and critical. Severe, we know oxygen saturation less than 90% on room air, respiratory rate more than 30 in adults, or respiratory rate in children. And then this is some COVID-19 variants may spread more easily. And then now some variant of COVID-19 spread more easily between people. We can control the spread of COVID-19 and its new variant. We can washing our hands, staying at least 1 meter, wearing a mask, and limiting time in our finding enclosed or crowded spaces. This is WHO label alpha, beta, gamma, delta, and kappa, epsilon, eta, rota. How to prevent COVID-19? Be aware. Sometimes we know about symptoms. Sometimes may appear 2 until 14 days after exposure to the virus. Common symptom and severe cases. How is it transmitted? Through close contact and by touching contaminated object. And be aware, people over the age of 60, people with pre-existing conditions such as diabetes and heart disease. Prepare, make sure to obtain all information from a reliable source. And we know about treatment, tocilizumab. Tocilizumab road interleukin-6 receptor block. And tocilizumab is dosed at 8 milligram per kilogram. And then about impact of the COVID-19 pandemic on TB management. WHO explained TB notification sustained over successive months have been observed in 2020 in several high TB burden countries as measure to respond introduced. Modeling work suggests that if the COVID-19 pandemic led to a reduction of 25% in expected TB detection for months, and then between 2020 and 2025, an additional 1.4 million TB deaths will be registered as direct consequence of the COVID-19 pandemic. To be conservative estimate, as they do not factor in other possible. The immune status that makes people vulnerable to tuberculosis may also make them stable to coronavirus infection. COVID-19 is already affecting control measure for tuberculosis, whereas possibility of co-infection should be kept in mind. WHO, people ill with both TB and COVID-19 may have poor treatment outcome, especially if TB treatment is interrupted. Prevention measure must be put in place to limit transmission of TB and COVID-19 in congregate setting in healthcare facilities. And then provision of TB preventive treatment should be maintained as much as possible. Existing WHO recommendation for infection prevention and control for TB and for COVID-19 should be strictly implemented, including personal protection equipment. Accurate diagnosis tests are essential for both TB and COVID-19. Tests for the two conditions are different and both should be made available for individuals with respiratory symptoms, which might be similar for the two diseases. Considering COVID-19 primarily during this pandemic day, we should not forget one of the great imitators to tuberculosis. The effect of missed or delayed TB diagnosis likely will be severe for affected person and hospital. Treatment and care, people-centered outpatient and community-based care should be strongly preferred over hospital treatment for TB patients, unless serious conditions are requiring hospitalization to reduce opportunity for transmission. Provision of antibiotic treatment must be ensured for all TB patients, including those in COVID-19 quarantine and those with confirmed COVID-19 disease. Adequate stock of TB medicine should be provided to all patients to increase chance of cure and reduce transmission and the development of drug. We can use of digital technologies should be intensified to support patients and programs to improve communication, counseling, care, and information management. And then detection and effective supportive treatment may reduce morbidity and mortality COVID-19 and TB. Because several risk score for COVID-19 and independent risk factor for TB including among other age, poverty, malnutrition, and comorbidities. TB patient, approach 50% if left untreated, and maybe higher in the elderly or in the presence of comorbidity. Support for uninterrupted TB preventive treatment and treatment of TB sure onset the COVID-19 response. And then TB services are not disrupted during the COVID-19 response, and COVID-19 could have a severe impact on case detection and treatment success. We know about WHO explained that all countries impacted by COVID-19 have had to change the way they deliver routine services, and an opportunity to incorporate lessons learned to improve TB programs going forward. Important to ensure that essential service and operation for dealing with long-standing health problems continue to protect the lives of people with TB and other disease or health conditions. Health service including national program to combat TB, need to be actively engaged in ensuring an effective and rapid response to COVID-19 while ensuring that TB services are maintained. And then the last is conclusion. The COVID-19 pandemic has caused substantial changes in TB care. TB and COVID-19 may have poor treatment outcomes if TB treatment is interrupted. Developing and strengthening policies to rapidly adapt TB countermeasure to the new challenge is a high and immediate priority. The pandemic response should be integrated into existing disease workforce to create synergies and strengthen health system in a transversal approach. And TB patients should take precaution as advised by health authorities and continue their TB treatment, bringing care close to patients, strengthening primary care, and proactively addressing stigma and fear. And health authorities should maintain support to essential TB service during COVID-19. People-centered delivery of TB prevention, diagnosis, treatment, and care service should be ensured in tandem with the COVID-19 response. Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much for Dr. Abul A'la for your presentation. So we can highlight the same thing actually about TB and COVID-19 pandemic. I highlight three same speaker highlight about using digital technologies for this kind of problem. So now it's time for us for Q&A. We already have 4 questions now, 2 for Dr. Safi and 2 for Dr. Calvin. So I will start first with for Dr. Safi. So the question is from Mrs. Munaya from Faculty of Public Health. I would like to ask Dr. Safi, the patients of tuberculosis have difficulties to go to the primary health care to get control their disease because beside the hospital, the public health center also used for COVID-19 care. We have interrupted care for TB patient in Indonesia because of COVID-19 care. How about in your country, or maybe in Canada, or maybe in Bangladesh? So please, Dr. Safi, the first question.
Yes, thank you so much. It is very interesting and very important question actually. As I mentioned in my talk, that COVID disrupt a health system or mobility and everything. So, and if you see the based on, I am away from Bangladesh last 21 years, so I cannot speak for them, but I can speak about Canada. So, you know, the Canada case is just increasing because Canada health system is complex. Canada also a diversity population, multicultural. Before going to the treatment things, I need to talk about the context. So internationally born people who migrate to Canada is one prone of disease of TB. Second is indigenous population. They have a huge number. And then third is the Canadian born. So you can see the case incidence rate is 4.5 or 6 per 100,000. So if you calculate, like Canada is only 37 million population, you could see not so much case, but a case is very expensive to treat in Canadian setting. In some cases, around 500 to 600 or say $700 per case we have to per month cost. But Canadian government not only giving the treatment on the drug, they also design that income supplement and culturally sensitive care, and also accessible all these facilities they need. Example, basic food supplement, nutrition, and that's important, and also partnering with the.
I think you are mute, Dr. Safi.
Sorry, can you hear me? Okay.
Yeah, okay.
I don't know. So let me start again. Canada is health system is complex because our population is a multi-diversity and origin. Canadian born, indigenous born, indigenous Canadian, and also internationally born, and the foreign born immigrants. So all immigrants and indigenous population is a part of the Canadian TB cases, and these cases about 4.5 to 4.6 per 100,000. And Canada population is not more than 37 million, so case is not so high, but expense is huge. Huge. And I can see this expense not only treatment, giving the drug, the 4 or 5 drug, is also expense related with the income supplement. So you could imagine that due to COVID, there is many people lost their job, and people still doing the lifestyle the same before because they have income supplement, and they have a culturally sensitive services, like people coming from different background, they feel comfortable their own native provider, and also some other aspect, and this also addressed and accessible to the services like essential services like a home, a shelter, and nutrition and food supplement. All together is a package of COVID, of TB management. So that's the reason, even though COVID is not interrupt much, because in developed nation, they organize very nicely. And as I said, the innovation is there, and Canadian is very much ahead of the innovation of technology. So the information, the counseling, everything now goes to online. So everybody is just used to this. So I don't think there is a much disruption, but there is some disruption due to misinformation. People was panicking, as you know, COVID information primarily when we did last year, remember, Narila? We have a lot of conversation, many things we don't know, unknown things. That's maybe reason to people stay home or not going to the health center. But after a few months, and we already catch up all the information, and already we have a situation to serve virtually, and that's why they are easy to get all the services. Like example, I'm taking some medication for my cholesterol or reflux disease, so I don't need to go to health center. I don't need to go to doctors. I just call the pharmacy, and then pharmacy just send you a medication at your doorstep. So just a couple of hours is required. The same thing in Canada. Every pharmacy they have the prescription and the patient record. Easily they can supply the medication in their own time with explanation with the service you need. So it's no cost because we have a insurance. The insurance cover, and government health insurance cover this kind of thing. And for HIV, TB also is covered, or some other agency, the supplement, we call it Public Health Agency Canada, and Canadian Tuberculosis Society of Canadian Lung Association. All they work together to make it happen. That's exactly I can tell you, because Canada is a complex health system with a complex of community background, That's why it's easy to imagine that may be a problem, but actually not at the scale.
Yeah. Thank you, Dr. Safi. I think it's related to the next question from Mrs. Andriani that you already mentioned about the support medicine and then income supplement, but what alternatives that in the Canada do related to supervision? Because in Indonesia, it's like directly observed therapy dot. It's restricted maybe during social distancing, national quarantine. How about in Canada? So about the how to supervise the TB patient that regularly consume the medicine.
A very interesting question. Yeah, normally we have a public health nurse or community health volunteers. They not supervise, they follow up. They call it supervise because Canada is a developed country and they have so many rights, so many privacy. So you cannot interrupt people's private life. So once you prescribe, you have to understand they have their own responsibility to take it. Our job is to motivate to change their behavior to a positive way. So nurse midwife cannot question them, but they cannot motivate them. You know what? For the goodness of your health, your family, society, is your obligation to take your medication. That's it. They can ask you today when you took this medication. Show me. No, this is just instruction or motivational promotional paper they can provide. That's it. Information is enough, but they cannot question because it's not mandatory. It's not like other developing country can do. We have so many rights and privileges. Even people cannot be labeled, oh, he is the TB patient, he is the HIV patient. No. So everybody has the dignity. So everybody has the right and freedom. So once you have this kind of prescription and drug, is patient's own motivation, they always take these things because they understand the importance of this.
Okay, thank you, Dr. Safi, for your answer. But there, I think now it's midnight, right? Yeah, but
oh, yeah.
Please stay for a while because we almost end of our session. So
okay.
Stay tuned for this. Thank you very much. And now we move to Dr. Calvin. Actually, there are 3 questions to Dr. Calvin, but I think this question is related each other. So I will read all. So the first question, how to motivate TB patient during this pandemic to consume the medicine regularly? Because the challenge in the community, they don't obey the instruction, right? Related to my question before. So what do you think the step? So it's from the TB patient. And the next question is from Karima is, how to motivate the healthcare provider in Philippines to motivate people. So it's a kind of both of sides about this issue. And also for the Mrs. Dewi Purnamawati, she said that thank you for the nice sharing, and there's a explanation about TB care in the Philippines, but when we say about program, our challenge is sustainability. So how Philippines can maintain the sustainability, especially there is a new innovation about digital technology utilization. How about the time, about the program achievement, maybe the target? So how about people in rural areas to challenge about digital technologies, for example? So please, Dr. Calvin.
Actually, let me answer the third question first. Sustainability. What is happening in the country as an outsider, as not, I'm not a member of the Department of Health, but rather part of the academy of the University of the Philippines, is that what is happening right now is we are reactive, no? And of course, we have our goals for 2022 and 2035. So what we want to do to actually meet the global mandate is for us to conduct certain activities that was already, suggested by WHO, Stop TB, etc. Sustainability is always an issue, but of course, as I presented earlier, a lot of the local government units, because similar to Indonesia, we have a devolved system, are now encouraged to actually raise funds And aside from these funds, the corresponding local government units are also enacting their localized version of national mandates and policies. So I think that's crucial. That's actually crucial when it comes to sustainability. I won't say that there's any magic or special sustainability ingredient for any of the programs. And I believe it's not only for TB, but number one, we're very happy that we do have the policies in place, especially for COVID-19 and TB, no? As for the two other questions for the patients, I wanted to go back first to the TOT program. No, frequently it consists of more than five elements. It includes incentives, tracing of defaulters, legal sanctions or policies, patient-centered approaches, staff motivation, supervision, and additional external fund. And focusing on the DOT itself, no, seems to be inappropriate. So it's a multiple component. This might account for some of the successes of DOT programs. And it's not so different actually when we do our when we provided free medicines that are good for 1 month. Improve patient counseling and communication through the use of the cell phone, the mobile phone, was actually very helpful to check on a frequent basis if the patient is actually taking their medication. I think the gap on the DOTS, especially for those individuals who have to report, no, they have to come to the health facility. And at times, most of these individuals, if we understand the socio-economic background of our patients, are those who are busy in tilling their lands, farmers or fisher folks, or housewives, who are very busy with their day-to-day work, and it's very difficult to include in their schedule to go to the clinic, to the healthcare facility. And given that we, like, the Philippines is a tropical nation, when it rains, and as one, the inclement weather in the country would actually limit them to complete even their medication. So what happens currently, other than of course the supervision through communication through the smartphone, no, and I believe everybody has a smartphone, or if not, in some cases, we partner, or the local DOTS partners with their carers or their families to actually ensure that they are taking their medication accordingly. And I think if the medicine is readily available and there we have the set cards, and further health education and supervision, they are able to complete the necessary and comply, no, to this treatment. So I hope I was able to answer that. It's surprising because a lot of people are more keen to receiving text messages and then reminders instead of coming to the facility. So it's a learning to us that we could actually have this the treatment or even the screening process nearer to the people, no, picking up their sputum, etc. And that's one of the learnings of this pandemic. As for the next question on the healthcare providers, incentives. The healthcare providers, especially the barangay health workers or the village health volunteers, you know, well, I think it's similar also in Indonesia.
Like cadre, right? In
Yeah, in the cadre.
Posyandu, yeah.
And they have a lot of tasks. It's not only TV, for one, in the Philippines, I should say that we have Republic Act 7883. Hopefully it will be enacted soon, no? The Barangay Health Workers Benefits and Incentives Act, no? Where certain benefits and incentives are actually awarded to these PHWs. And in addition to that, as I mentioned earlier, the local government units have actually their own policies. And with those policies, these laws, no, and particularly on TB, addressing TB concerns, TB control and management, our barangay health workers would be following, how should I say, are enacted to actually conduct these activities in order to decrease, if not eliminate, TB cases in the community.
Yeah.
Thank you.
Thank you, Dr. Calvin. It's interesting about COVID TB caravan, right? in Philippines, right? Okay, please stay tuned because I will move to a question for Dr. Abul A'la. So the challenge of TB during pandemic COVID-19 pandemic is about just diagnostic and treatment. In Indonesia, the endemic area of TB, how about we choose easy TB with secondary bacterial infection or COVID? Because COVID itself has many forms of radiological finding. Does every patient have to check for gene experts sputum and PCR to start the therapy? Please, Dr. Abul A'la.
Okay, thank you very much for your question, Ms. Indri. We know about incidence of tuberculosis in Indonesia. The WHO has defined Indonesia a high burden country for tuberculosis. There are 22 high burden countries worldwide, and together they count for about 80% of the world tuberculosis infection. Tuberculosis, TB, and COVID-19 are both infectious diseases that attack primarily the lung. So my presentation before, tuberculosis and COVID-19 are both infection diseases that attack primarily the lungs. Both diseases have similar symptoms, such as cough, fever, and difficulty breathing. And TB, however, has a longer incubation period with a slower onset of disease. While experience on COVID-19 infection in TB patient remain limited, anticipated that people ill with both TB and COVID-19 may have poor treatment outcomes, especially if TB treatment is interrupted. TB patient should take precaution as advised by health authorities to be protection from COVID-19 and continue their TB treatment as prescribed. And the answer is accurate diagnostic tests are essential for both TB and COVID-19. TB laboratory networks have been established in countries with the support of WHO and international partners. This network, as well as patient specimen transportation mechanism, could also be used for COVID-19 diagnosis and surveillance. But first, in this pandemic area, we have exclude the COVID first, and we have test the PCR for COVID first. And then, but if we see in X-ray, fibroinfiltrate on radiological finding, we can check both gene expert and PCR for COVID. And we can start therapy simultaneously both TB and COVID. Okay, thank you very much.
Okay.
Moderator.
Okay, yeah, so it's the challenge, right, Dr. Abul A'la, to if the patient have to kind of this disease. So I think we really want to continue this meaningful discussion, but unfortunately the time is limited. So let me conclude our session with some points that first, yes, we have a challenge to manage TB during COVID-19 pandemic, but this pandemic gives us a lot of experience how to handle TB cases by using the digital technologies, finding new method to detect and screen about TB, and infection prevention control during this pandemic because of COVID-19 could be a permanent behavior actually to prevent the transmission of TB in a general term. So, and the adaptation for TB care we should do for and to manage the sustainability of the program, so we can end this pandemic and also we can reduce the TB cases in the same time. So again, thank you very much, Dr. Safi, Dr. Calvin, and Dr. Abul A'la for your valuable sharing to express our appreciation. We would like to give you certificate for each. So committee can help me to share the first for Dr. Shafi, the certificate for Dr. Shafi. Can you share? Yeah, this is our certificate of presented to Dr. Safiullah Buyan, PhD in recognition and appreciation of your contribution as speakers in our first Muhammadiyah International Public Health and Medicine Conference. Thank you very much, Dr. Safi, for your sharing a very good thing. Thank you. And then next, okay. It's already take the picture, the committee before with Dr. Shafi with the with the certificate. I think yes. Okay.
Thank
Next,
you.
for Dr. Calvin. Okay. Can you share for Dr. Calvin certificate? Okay, this is for Calvin de los Reyes, PhD, for your contribution. Thank you very much.
Thank you very much. Terima kasih.
Okay, so the next one is for Dr. Abul A'la. Please.
Okay.
So please wait for a moment. Okay, it's for, okay, it says our certification for Dr. Abul A'la Al Maududi for your contribution. Thank you very much,
Thank
Dr.
you.
Abul
Thank you.
A'la.
Thank you very
Okay.
much.
Okay, thank you for all participation for this session. Please let me remind you that after the break, we will have a second session with the other three great speakers. So please don't miss it, right? So I, Narila, would like to say thank you very much for your participation, for your time, for all the very great speakers. Thank you very much for your time. And I will give it back to the MC, Karima and Dinda. Thank you very much, Dr. Shafi, Dr. Calvin,
Thank
and
you.
Dr. Abul
Thank you
A'la.
also,
Thank you,
Tia.
Dr.
Magandang
Shafi.
gabi
Thank
po,
you,
moderator.
Dr.
Excellent
Dr. Calvin.
moderator.
Thank you, Dr. Calvin.
Thank
Thank
you.
you. Thank you.
Test. Okay, thank you for our Mrs. Narila Mutia Nasir, Bachelor, Master, and Doctor of Philosophy of Public Health for guiding the event and this conference. The speakers are amazingly great. Hopefully, what the speakers has described will guide a blessing and become a charity in the hereafter. Amin, amin, ya robbal alamin. Before we continue to the second presentation session for all of participant conference today, allow to break for praying Zuhur, who have about an hour to rest for a while. It is hoped that all participants will return on time at 12:30. And the announcement for this conference will have a take in 2 days. Today is on Thursday, 29th July, and for tomorrow on Friday, 30 July, which is tomorrow for the participant of research result from each participant at 9 a.m. Then for the group of moderators from Miss Narila, Miss Dewi, and Miss Triana Sintrantrioni, Miss Triastika, and Mr. Baikuni, it will start at 11 because there has to attend the inaugurations IACME event. And don't forget to open and read it the program book of this conference. Thank you.
menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Tuhan di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Tuhan di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mempromosikan hidup sehat. Sehat adalah anugerah Tuhan di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Tuhan di manapun. gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah, menang di manapun. gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Tuhan di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Tuhan di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Tuhan di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah Tuhan di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. dan cita-cita masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah menang di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah menang di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah menang di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah menang di manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah menabi manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah menabi manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah menabi manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah menabi manapun. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah.
Assalamualaikum.
Bismillahirrahmanirrahim. Ladies and gentlemen, please pay attention. For all of the participants of conference, before continuing the second session, I remind for all of the participants, don't forget to fill in attendance list at the column chat that we have prepared. Turn off the audio when the event starts and open the camera during the event. Thank you. Okay. For the second session, allow me to read the CV from our moderator. Moderator, Munaya Fauzia, Bachelor and Master of Public Health from University of Indonesia. Candidate Doctor of Public Health at Doctoral Program University Diponegoro. Work experience, lecturer at the University of Muhammadiyah, Jakarta from 1999 until now. She has many activities such as book translator. She has 32 journal publications. She has carried out 14 community service activities and many more activities that have been obtained. Mrs. Maria Fauzia, time is yours.
Masih unmute.
Thank you, Karima and Dinda. The Honorable Rector and Vice Rector, University of Muhammadiyah, Jakarta. The Honorable Dean and Vice Dean, Faculty of Public Health, University of Muhammadiyah, Jakarta. The Honorable Dean and Vice Dean from Faculty in University of Muhammadiyah, Jakarta. The Honorable President of Indonesian Public Health Association, Jakarta Region. The Honorable Speakers and all of the participants. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon and also good morning and good evening for the participants around the world, wherever you are who listening. This is Thursday, 19th July 2021. My name is Munaya Fauzia. Please allow me to lead this session as moderator. I am welcoming you to the first Muhammadiyah International Public Health and Medicine Conference focused on management for tuberculosis control during COVID-19 pandemic. The world's attention is currently on the COVID pandemic, but other diseases such as tuberculosis are also important and need attention so that the number of incidents can be inhibited and also the mortality can be suppressed. Therefore, we have special speaker today in our second session in this noon. I would like to introduce the speaker today. The first is Mr. Dr. Muhammad Fakhri, lung specialist, fellow of Indonesian Society of Respirology, and fellow of Asia Pacific Society of Respirology. Welcome, Dr. Fakhri. Are you already joined with us?
Yes. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you. And our second speaker is Mr. Dr. Rizky Akaputra, lung specialist and fellow of Indonesian Society Respirology. And the last but not least, Mr. Febi Dwi Rahmadi, MPH PhD from Griffith University, Queensland, Australia. Is Dr. Rizky Akaputra and Dr. Febi already joined with us?
Hello, how are you? Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh. Welcome. Okay. With this, let me hand over to Dr. Muhammad Fakhri first as the first speaker. Dr. Fakhri will deliver material regarding lung tuberculosis and types 2 diabetes mellitus in acid-fast basally EFB smear. Please. Yeah, I would like to read Dr. Fakhri curriculum first. Yeah. Dr. Fakhri is lung specialist, got his medical degree at Trisakti University in Jakarta, and got his doctoral degree at Faculty of Medicine, Hasanuddin University, and now is Dean of Faculty of Medicine and Health, University of Muhammadiyah, Jakarta. And Dr. Fakhri is also Chairman of Medical Committee Singapura Islamic Hospital of Jakarta, Chairman of Tuberculosis Team Sukapura Islamic Hospital Jakarta, member of Fellow Asia Pacific Society of Respirology, member of American Thoracic Society, and member of European Respiratory Society. Okay. Please, Dr. Fakhri, the time is yours.
Okay, thank you, Ms. Munaya. First, Assalamualaikum warahmatullahi wabarakatuh. Our Honorable our Rector and Vice Rector, and then Dean of the Faculty of Public Health, University Muhammadiyah, Jakarta. First, I would like to share about the tuberculosis and diabetes mellitus. Yeah, otherwise, there is the important thing. This is the important thing that we get in the situation of pandemic about the tuberculosis. Can I share? I will present in the other side. I will present a few research, and based on the big research about the tuberculosis and diabetes mellitus. As we know, Global Tuberculosis Report 2014, Indonesia is included in the top 6 countries in the world with the highest number of pulmonary cases. It's with India, China, Nigeria, Pakistan, and South Africa. And then since 2015 and 2021, with a few great change of the grade, Indonesia today is rises to second place in the world with the largest number of pulmonary TB cases after India. And there's a few data from our research in Jakarta, in one of the hospital. There is the age of the patients of tuberculosis is more than 18 until 49 years old. There is quite young people, and then more is male than female. And then what is it? From the presenter, there is a few symptom of the tuberculosis, like the bloody cough, and then shortness of breath, productive cough, and then cough is more than duration is more than 2 weeks, and then fever. There is we can find a lot of symptoms in our patients in our clinics, and then X-ray is the real of the picture of the tuberculosis, and then the level of education of the patient is the high school, not the higher students, and then a worker almost is unemployment, and then housewife. Based on the diagnosis of suspected pulmonary tuberculosis, there is some lesions of the patients of the tuberculosis more, and pulmonary TB is to 299, and then based on AFB from the smear, positive TB is more than negative than the positive. The other data from the other journal that we have published that is almost the same. There is the younger, as the age is younger persons, more than a male. I think there is, what is it? In the male is more like smoking people, and then it can damage our her or his what is it, lungs structures. And then from the blood, from the hematological parameters, we can know as the base examination of the people that examination of the tuberculosis first. Yes, electrolyte sedimentation rate is more higher this many cases, and then hemoglobin, hematocrit, and leukocyte is more normal than higher, and thrombocyte is quite range in normal range. And specific with the type 2 diabetes mellitus, in one of the important risk factor in the occurrence of TB inflammations, especially in the situations of pandemic COVID-19. It can be damage of the structures of the lung and the other structures, and then it can be more decrease about the disease of the patients. And then clinicians have observed an association between DM and diabetes mellitus and tuberculosis, although it is still difficult determining whether diabetes mellitus precedes TB or TB that leads to clinical manifestations of diabetes mellitus. It's known that the diabetes patients have impaired the body immune response so as to facilitate Mycobacterium tuberculosis infection and cause tuberculosis. One of these research is to know comparison between acid-base FB smear result from Mycobacterium tuberculosis on adult pulmonary tuberculosis patients with type 2 diabetes mellitus, and acid-base smear result from the tuberculosis on adult pulmonary TB patient without type 2 DM. There is concept, there is type 2 with the positive FB and the negative FB in the pulmonary TB. And then populations from the first research and then second. And then this correlation in diabetes mellitus in the same hospital, we can first 459 patients. It's known that tuberculosis is still the highest disease that we can find in the clinics, especially in lung clinics. There is an inclusion criteria, and then we collect sample to 125 patients. From the results, same the previous study, we can see that gender male is more than female, and then the age is quite similar, but the adult persons is more than younger persons. Type of TB patients is new cases with the treatment of other category. Category 1 is 33.8%. Treatment results and then the recovery from the after get the other category. That's category 1 and 2 is 38 patients. If we see the FB examination result in patients with pulmonary TB are accompanied with type 2 diabetes and with out of type 2 diabetes. We can see that the pulmonary tuberculosis with the diabetes mellitus type 2 and pulmonary without accompanied by type 2 diabetes mellitus is more FB examination result is and positive of the FB examination is more than in the pulmonary TB without type 2 diabetes mellitus. How about the examination of the diabetes mellitus that we can find from the patients from tuberculosis? First, we can get from the blood glucose more than 200 is with the positive result examination is 26 and less than 200 is 28. From the free blood gas of the glucose, we can find free blood gas more than 126 is with the positive FB examination is more than less than 126. It can do with the blood glucose postprandial is more than 200 is 36. It means that the highest of the blood glucose we can find the highest or the positively of the acid phase basal examination result. What is the relation of type 2 diabetes with FB examination result? In the pulmonary tuberculosis with diabetes mellitus type 2, FB examination result is with the positive of the FB examination is more than in the pulmonary with diabetes mellitus in the negative result. In many journal, FB smear with negative result was found in the result. FB smear with positive result were more prevalent in patient with diabetes mellitus type 2. And FB conversion at the end of intensive phase. And there are statistically significant association with between type 2 diabetes mellitus and FB smear result. From this research and few previous research, we can find that the patients who have adult pulmonary TB smear positive test results are more common in adult pulmonary TB patients with blood glucose levels, free blood glucose or blood glucose postprandial increase. In adult pulmonary TB patient with smear positive test results are more common in adult pulmonary TB patients, where accompanied disease type 2 diabetes compared to adult pulmonary TB patients who are not accompanied by disease type 2 diabetes. There is a statistically significant relationship between the level of BG, FBG, and BGPB and type 2 diabetes mellitus disease with the result of smear examination in adult pulmonary patients. I think in situation of pandemic COVID-19, in the patient with the tuberculosis, with the comorbid diabetes mellitus, if he get to the COVID-19, it can be more decrease the situation of this patient, and the prognosis will be bad than without the comorbid diabetes mellitus in patients who get the COVID-19 with the tuberculosis. I think that my presentation. Thank you very much.
Thank you very much, Dr. Fakhri. It's a very, very interesting result of the research about which one is the first coming to the person, diabetic first or tuberculosis first, and what happened with someone if they also got COVID-19. It's very interesting, and I know many participants would like to ask a question, but please hold on first, because we have to continue to our next speaker. So you can keep your question, and you can also deliver your question in our chat room. But now we continue to our next speaker. I would like to introduce Mr. Rizky Akaputra. Mr. Rizky Akaputra, lung specialist. Okay. Dr. Rizky Akaputra, lung specialist, fellow of Indonesian Society of Respirology. He got his lung specialist at Faculty of Medicine, University of Indonesia, and now is Vice Dean Academic of Affairs at Faculty of Medicine and Health, University of Muhammadiyah, Jakarta. Besides his activities as a lecturer, he served as a doctor at Kopura Islamic Hospital Jakarta, at Regional Public Hospital Pasar Minggu Jakarta, and at Columbia Asia Pulau Mas Hospital. And Dr. Rizky will deliver material regarding diagnosis and serve tuberculosis on pandemic COVID-19. Okay, please, Dr. Rizky, time is yours.
Okay, thank you very much, Bu Munaya, Mrs. Munaya. Maybe I will make it different with other presentation. I will using bahasa if you don't mind.
Of course, because many of the presenters is Indonesia, we have only.
Okay. Oke, terlihat ya tulisannya?
Terlihat, Pak.
Oke, terlihat. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang semuanya. Jadi pada siang hari ini saya akan sedikit berbagi bagaimana kita melihat penegakan diagnosis dan pelayanan TB pada saat kondisi pandemik COVID-19. Jadi mungkin kita kembali ke berapa tahun, 2 tahun ke belakang. Pertama kali ditemukan pada tahun bulan Desember 2019 itu dilaporkan ada suatu kondisi yang sangat-sangat akut dan berat ya, yang didapatkan sebagai atau dinamakan sebagai pneumonia Wuhan pada saat itu. Dan kemudian sebulan setelahnya diidentifikasi bahwa penyebab pneumonia Wuhan tersebut adalah sebuah virus yang kita sebut dengan SARS-CoV-2. Nah, kemudian di bulan yang sama WHO menegaskan bahwa pembagian penyakit tersebut sebagai COVID-19. Nah, kemudian pada tahun 2020 di bulan Maret, yaitu tanggal 2, pertama kali Presiden Joko Widodo mengumumkan bahwa telah ditemukan kasus pertama dari COVID-19 yang ada di Indonesia. Dan di bulan yang sama, WHO mengumumkan bahwa kondisi dunia pada saat ini sedang mengalami pandemi. Dan disinilah bermula dan terjadi perubahan-perubahan yang cukup signifikan dalam berbagai sektor kehidupan kita maupun dalam berbagai pelayanan kesehatan, terutama terkait dengan pelayanan kesehatan yang sifatnya berbentuk sebagai satu tujuan pembangunan yang berkelanjutan, terutama tentunya pada pasien-pasien yang terinfeksi dengan TB. Nah, mungkin kita bisa melihat kasus yang COVID-19 pada hari ini sudah mengenai 222 negara dengan kasus yang terkonfirmasi di Indonesia itu sebanyak 3,2 juta. Ya, kemudian dengan kasus aktif sebesar 558.000, yang dinyatakan sehat sebesar 2,6 juta, dan dengan angka kematian yang cukup tinggi sebanyak 88.659 orang. Sedangkan kondisi di Jakarta itu hampir mendekati angka 1 juta kasus yang terkonfirmasi, dan pasien yang sedang dirawat atau sedang melakukan isolasi mandiri pada saat ini sebesar 35.397 orang, dengan orang yang dinyatakan sehat sebesar 757.000. Dengan angka kematian yang cukup tinggi juga sebesar 11.688. Nah, secara global, seperti yang sudah diutarakan sebelumnya bahwa angka kematian TB itu cukup menjadi yang terbesar ya di dunia terhadap penyakit infeksi. Nah, estimasinya sekarang ini orang yang terkena TB pada tahun 2019 itu sekitar 10 juta orang, dengan angka kematian orang dengan HIV negatif 1,2 juta, dengan HIV positif sebesar 208 kematian. Untuk dewasa lebih dominan untuk yang terkena TB dibandingkan anak-anak. Nah, kemudian untuk kasus yang terbesar itu berada di Asia Tenggara, kemudian diikuti oleh Afrika dan area Pasifik, dan 8 negara yang terkena TB itu dengan peringkat Indonesia cukup tinggi ya, di peringkat nomor 2 dengan terbanyak di India. Nah, pada saat pandemi COVID dan penanganan tuberkulosis, kita dihadapkan terhadap dua penyakit yang secara klinikal, secara gejala klinis itu hampir sama. Kemudian dia sama-sama mengenai organ paru, kemudian secara komorbid juga hampir mencakup jumlah komunitas yang sama, dan transmisi mungkin secara ini tidak secara transmisi mungkin ada sedikit perbedaan, tetapi banyak kesamaan. Begitu juga dengan melakukan tahapan-tahapan pencegahan. Nah, yang terjadi adalah pada saat kita bertemu dengan ada dua hal ya, dampak terhadap pasien TB. Kalau kita lihat report dari data Kementerian Kesehatan yang dilaporkan tentang TB, itu penemuan kasus pada tahun 2019 dibandingkan 2020 itu terjadi penurunan yang cukup signifikan, dan kemungkinan yang kita khawatirkan terjadinya under atau over diagnosis terhadap pasien TB tersebut. Nah, untuk dilihat gejala, bagaimana kita bisa membedakan antara gejala pasien TB dengan pasien COVID-19. Nah, ini saya ambil data dari BNPB ya, yang mencakup gejala-gejala yang paling sering diderita oleh pasien COVID-19. Kita bisa melihat gejala respirasi itu menduduki di dalam 5 besar itu mencakup 3. Ya, ada batuk, ada sesak nafas juga. Nah, kemudian untuk gejala, dan ada pilek juga ya. Kemudian untuk gejala demamnya, ya ini ada di pasien TB juga itu memiliki gejala yang sama. Jadi bagaimana kita membedakan apakah gejala yang muncul pada pasien yang datang ke poliklinik kita atau ke rumah sakit ini merupakan COVID-19 atau merupakan satu tuberkulosis, karena organ yang terkena dan gejala klinisnya hampir sama. Sedangkan untuk komunitas ya, pada pasien COVID-19 itu juga menyerang pada usia tua dan cukup berat pada orang-orang dengan usia tua, dengan angka kematian usia lebih dari 60 tahun juga menduduki peringkat yang paling besar. Untuk faktor komorbid sendiri ya, untuk pasien TB juga memiliki risiko yang cukup tinggi juga pada pasien-pasien penderita diabetes mellitus. Kemudian pada pasien-pasien yang memiliki gangguan paru yang cukup kronik, ini juga menjadi salah satu faktor komorbid bagi pasien-pasien tuberkulosis. Sehingga pada pasien-pasien penderita tuberkulosis terkadang ada rasa ketakutan untuk mendatangi fasilitas pelayanan kesehatan, karena di awal pandemi ada stigmatisasi terhadap pasien-pasien COVID-19, sehingga pada saat terinfeksi penyakit saluran nafas cenderung untuk tidak menampakkan atau tidak melakukan kunjungan ke fasilitas pelayanan kesehatan. Nah, untuk transmisi secara garis besar ya, secara itu transmisi yang terjadi pada pasien COVID-19 mungkin tidak sepenuhnya sama, tetapi ada hal yang sama terkait dengan transmisi, yaitu pada pasien TB dan COVID-19 itu memiliki riwayat kontak erat. Nah, perbedaannya adalah kontak erat pada pasien TB itu biasanya terjadi pada orang-orang atau ditularkan pada orang-orang yang memiliki gejala, terutama yang memiliki gejala batuk yang produktif. Ya. Sedangkan untuk COVID-19, ya, kontak erat ini biasanya pada orang yang terinfeksi COVID-19, tetapi bisa ditularkan melalui orang-orang yang tidak bergejala maupun orang-orang yang bergejala. Sedangkan penularan yang bisa penularannya sama-sama bersentuhan atau kontak dengan droplet yang dikeluarkan, baik itu oleh pasien TB maupun pada pasien-pasien COVID-19. Nah, bagaimana kita mendiagnosis TB ini agar kita tidak berlebihan, juga tidak terlewatkan untuk diagnosis TB. Karena kalau kita melihat dari sejarah sejarah penyakitnya, ya kita bisa melihat bahwa kalau TB itu merupakan satu penyakit yang kronik. Artinya dari masa inkubasi TB biasanya mulai dari berapa bulan dan bisa dalam bentuk tahunan. Dan ini tentu saja berbeda dengan COVID-19 yang masa inkubasinya itu sekitar 7 sampai 14 hari. Sehingga dalam melakukan anamnesis atau wawancara terhadap pasien, kita harus menggali benar-benar keluhan tersebut terjadi di onset yang kapan, kemudian durasinya berapa lama. Dan ini juga kita harus mencoba menggali apakah ada kontak atau orang yang terkena penyakit yang sama di keluarga atau di orang sekitar pasien. Nah, kita juga dapat membedakan pada kasus-kasus tertentu ya untuk pasien tuberkulosis. Kalau seandainya kita melihat gambaran kavitas, kemudian gambaran ektasis yang cukup luas, ini mungkin kita bisa mengarahkan spesifik untuk TB-nya, tetapi tanpa mengabaikan COVID-19-nya. Nah, sedangkan untuk yang menyulitkan adalah pada saat kita melakukan pemeriksaan chest X-ray atau fototoraks, itu didapatkan gambaran ground glass opasitas yang mungkin bisa juga terdapat pada pasien-pasien TB dan bisa juga terdapat pada pasien COVID-19. Nah, ini untuk kita harus kembali lagi merujuk kepada riwayat kesehatan pasien, apakah pasien tersebut mengarah ke arah satu penyakit yang kronik atau satu kondisi yang akut terhadap TB-nya. Dan kemudian untuk gold standar pemeriksaan tuberkulosis, kita bisa menggunakan tes cepat molekuler, ya, itu dengan memeriksa ada atau tidaknya kuman Mycobacterium tuberculosis, atau bisa juga melakukan swab PCR pada pasien COVID-19. Atau bahkan sekarang juga di sebagian tempat kita menggunakan tes cepat molekuler yang ditujukan kepada pasien-pasien COVID-19, sehingga untuk mendapatkan diagnosis yang lebih cepat dan lebih tepat itu dalam waktu yang cukup ringkas. Nah, kondisi penyakit pada paru pada saat kita sudah mendiagnosis TB, ini juga yang harus kita ingat adalah jangan sampai kita melewatkan kondisi infeksi akut ya seperti COVID-19 tersebut, sehingga kita dapat mengidentifikasi pada pasien yang datang ke poliklinik maupun rumah sakit apakah pasien tersebut sedang terinfeksi TB saja atau COVID saja, atau pasien tersebut menderita kedua-duanya. Nah, ini diupayakan kita tidak melewatkan salah satu dari diagnosis tersebut. Nah, ini untuk bagaimana kita melakukan penapisan COVID-19 terhadap pasien TB. Nah, kita bermula misalnya pasien TB itu datang dengan keluhan demam atau memiliki riwayat demam sebelumnya. Nah, jika ada kita menggali kira-kira ada keluhan gejala respirasi atau tidak. Jika ada, nah ini kalau dulu kita berpikir ada riwayat berpergian atau tinggal di satu daerah yang memiliki insiden TB-nya cukup tinggi, tapi untuk kondisi di Jakarta ini sudah menjadi satu kecurigaan, ya, sehingga pada kasus-kasus ini kita dapat melihat jika dia bergejala, tentu saja kita beranggapan bahwa ini kemungkinan sebagai suatu probable untuk COVID-19 dan membutuhkan untuk pemeriksaan. Jika ini di fasilitas pelayanan tingkat 1, ini bisa dilakukan rujukan terhadap pasien tersebut. Nah, jika pasien tersebut tidak memiliki riwayat atau
Dr. Rizky, suara
ya.
Dr. Rizky, suaranya kemute.
Sudah terdengar suaranya? Bu Munaya? Oke, sudah ya?
Sudah terdengar
ya.
Sekarang.
Oke,
ya.
Kita lanjutkan. Ya, jika tidak ada atau bukan berasal dari daerah yang bukan terjangkit COVID, maka kita harus bertanya apakah ada kontak atau tidak. Jika tidak ada, kemungkinan ini bukan merupakan suatu suspek. Tapi untuk di Jakarta atau di daerah Indonesia lainnya tentu saja kita tetap meletakkan kondisi pasien dengan bergejala tersebut sebagai suspek terhadap COVID sampai kita menyingkirkan bahwa pasien tersebut bukan COVID-19. Nah, jika tidak ada riwayat demam ya, atau tidak ada demam pada saat pasien datang, ini tetapi memiliki gejala respirasi, ya, kemudian kita harus menggali terlebih dahulu apakah dia berasal dari daerah yang memang sedang terjadi insiden kasus COVID yang cukup tinggi atau tidak. Nah, jika ya maka kita anggap sebagai orang yang memiliki kecurigaan, apalagi dengan pasien-pasien yang berusia lebih dari 60 tahun. Tapi pada kondisi saat ini, ya, di tahun yang berbeda, tentu saja kita tidak melihat usia karena proporsi jumlah pasien terkait dengan usia sekarang yang muda juga cukup banyak yang terkena COVID-19. Nah, begitu juga jika tidak ada gejala respirasi dan bukan berasal dari daerah yang terjangkit COVID-19, kita memberikan edukasi bagaimana supaya mencegah atau melakukan tindakan preventif agar tidak terkena COVID-19 dengan melakukan protokol kesehatan yang cukup baik pada saat beraktivitas maupun berinteraksi dengan orang-orang lainnya. Nah, kemudian pada bulan Maret tahun lalu ini juga dikeluarkan oleh Kementerian Kesehatan itu protokol bagaimana melayani pasien TB. Mungkin saya bercerita sedikit, kalau pasien TB dengan program DOTS, ya, biasanya pasien yang sensitif dengan obat itu kita memberikan terapi selama 2 minggu, pasien kontrol, kemudian kita evaluasi satu kejadian efek samping obat atau keluhan yang memberat. Nah, sedangkan pada pasien-pasien TB dengan resisten obat, biasanya pasien itu akan berkunjung ya dengan waktu yang cukup sering, yaitu hampir setiap hari pada fase intensif. Dan pada saat jadi halo, suara saya masih terdengar?
Masih.
Oh ya, oke. Ya, jadi pada saat terjadi pandemi COVID, ini ada terjadi perubahan dalam pelayanan kesehatan, bagaimana kita melakukan rujukan terhadap pasien TB. Itu pada fase intensif pada pasien TB yang sensitif dengan obat, itu diberikan dengan rentang waktu 2 minggu atau 14 hari sampai 28 hari dalam rentang waktu yang di awal. Jadi diberikan 28 hari jika dalam evaluasi pertama itu tidak terdapat efek samping obat atau gejala yang memburuk. Sedangkan fase lanjutan itu bisa diberikan untuk rentang waktu 1 bulan sampai 3 bulan pengobatan. Ini tentu saja dalam rangka mencegah kontak atau mencegah dalam rangka menjalankan protokol kesehatan agar pasien TB tersebut yang memang rentan untuk terkena COVID terhindar dari infeksi COVID tersebut. Kemudian untuk TB yang kebal sama obat atau kita sebut dengan TB resisten obat, itu pada fase intensif yang harusnya diberikan setiap hari obat-obatannya untuk memantau efek sampingnya, tetapi pada masa pandemi ini dapat diberikan 7 hari. Ya, kita dengan menggunakan short treatment-nya. Ya, kemudian untuk fase lanjutan itu baru bisa diberikan 2 minggu sampai 1 bulan. Nah, kebetulan di rumah sakit tempat saya berpraktek itu dijadikan sebagai satu tempat rujukan COVID-19 sehingga pasien-pasien untuk TB sensitif obat ya kita rujuk ke fasilitas pelayanan kesehatan yang tidak melayani COVID pada saat itu. Kemudian sedangkan TB resisten obat itu kita rujuk juga ke rumah sakit yang membuka layanan TB tetapi tidak membuka atau tidak secara khusus melayani pasien COVID pada saat itu. Jadi rujukan itu kita mulai pada saat kita ditetapkan bulan Mei 2020, ya, sehingga dalam tahap awal 3 bulan sebelum
dilakukan rujukan, kita sudah melakukan beberapa persiapan, terutama edukasi terhadap pasien. Bagaimana melakukan APD yang baik, bagaimana cara melakukan 3M pada saat itu, belum 5M, belum 6M. Nah, ini mungkin dalam pantauan kita, pasien-pasien TB resisten obat yang kita rujuk ke tempat lain itu yang terkena COVID-19 itu ada 2 pasien, kemudian yang terkena, yang akhirnya meninggal, ada 1 pasien meninggal akibat terinfeksi COVID-19. Sedangkan yang lainnya bertahan dengan tidak terindikasi sebagai COVID-19. Sedangkan untuk TB sensitif obat, sampai 1 tahun ini kita belum memiliki data berapa orang yang terkena COVID-19 dalam perawatan di layanan kesehatan yang lain. Ya mungkin karena COVID-19 dan TB itu hampir memiliki gejala yang sama, kemudian mengenai organ yang sama dan memiliki transmisi yang hampir-hampir mirip, maka kita tetap fokus untuk menegakkan diagnosis TB pada pasien-pasien COVID, dan begitu juga sebaliknya. Dan untuk ketersediaan obat-obat TB atau informasi tentang COVID pada pasien TB, ini juga mesti kita pertahankan. Dan tetap berikan edukasi bagaimana cara pencegahan, baik itu di rumah tangga, baik itu di masyarakat, bagaimana cara melakukan etika batuk yang baik, bagaimana cara menggunakan alat pelindung diri pada pasien-pasien yang terinfeksi. Ini juga tetap kita lakukan lakukan edukasi terhadap pasien tersebut, dan juga kita menggunakan beberapa modalitas untuk melayani pasien TB untuk mencegah COVID-19. Misalnya dengan melakukan telemedicine pada pasien-pasien TB yang tidak memiliki gejala yang signifikan, sehingga tidak membutuhkan pemeriksaan dan perawatan yang mesti dikunjungi oleh rumah sakit. Mungkin sekian presentasi dari saya ucapkan terima kasih banyak atas perhatian yang diberikan. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Rizky. Thank you very much for the great presentation. We have also participants from Sweden today, but fortunately, our participants can also use bahasa, so it's okay. She will understand the presentation. Okay, and to all of the participants, please prepare your question regarding the lung tuberculosis and type 2 diabetic mellitus, and also regarding the diagnosis and self-tuberculosis on pandemic, which is delivered by Dr. Rizky Akaputra. And you can also write your question in our chat room. Please don't be hesitant to write down, and you can also write down in Indonesia. Thank you. And we continue to our third speaker, Ms. Dr. Feby Rahmadi, MPH, PhD from Griffith University, Queensland, Australia. Hello, Dr. Feby.
Hello, how are you, Mbak Munaya?
Thank you for joining with us. Alhamdulillah. Ini berapa lama ini perbedaan jamnya? How many differences in our
3 hours. So Brisbane is 3 hours ahead from Indonesia, Indonesian Western time.
Okay. So now it's 5 o'clock.
4:22 p.m.
4:22. Okay. I would like to read your biography first. Dr. Feby Rahmadi, PhD, is the course convener of Disaster Management and Resilience Building, Global Health Priorities and Intervention, and Health Program Planning, Monitoring, and Evaluation at Griffith School of Medicine. He has worked for many years as Disaster Risk Reduction Manager for the International Federation for Red Cross and Red Crescent Indonesian Delegation Office. His PhD research was collaborative governance model to link between climate change adaptation and disaster risk reduction to build urban community resilience. Okay, and now Dr. Feby Rahmadi can refer the material regarding ecological public health. And our first and the second speaker has already mentioned about diagnosis and diagnosis about tuberculosis, and now we have a different point of view to tuberculosis. We now can see the different point of view from ecological public health, right, Dr. Febi Dwi Rahmadi?
Yes.
Please, time is yours.
Thank you. Thank you, Mbak Munaya. It's a pleasure for me to be here, and I'm lucky to be the third speaker because the first and the second speaker has already provided the basic informations and also descriptions about TB, severity, the urgency, how to deal or how to manage TB risks in Indonesia. So thank you so much, doctors, for providing all those information. So I'm lucky to be the third speaker. Please allow me to share my screen. So I'd like to share my screen, and please let me know if you can see. Can you see my screen?
Yes.
Yes. Okay. So in the next maybe 15-20 minutes, or maybe about 20 minutes, please remind me if I go beyond maybe 20-25 minutes, because sometimes I like to talk a lot. So I would like to share a topic about ecological public health approach to manage tuberculosis risks during pandemic. So in our presentation today, we will cover at least 4 topics. The first one is, what does it mean by ecological public health approach? So this is something that we probably need to understand first, because we probably have understood public health, but what does it mean by ecological public health? Okay, then the second one is TB and COVID-19. There's a very interesting articles that says there are different diseases, but they have same challenges. Okay, and the third one is upstream thinking to deal with TB during pandemic crisis. So how we can make sure that we bring our healthcare upstream so that we can deal with these tuberculosis. And last but not least, I would like to share some takeaway messages for all of us. So let's go to the first one. So I'm not sure whether we all familiar with this guy. So this is Charles Edward Winslow. So he is an American bacteriologist, but he is also expert in public health. So what he says is that public health is the science and art of preventing disease, prolonging life, and promoting health. And this is what I would like to highlight here. Okay, talking about TB, let's say now COVID-19. So we all have to prevent all these kind of disease through organized community efforts. So this is a very important a sentence. Okay, so that is why in COVID-19, the WHO has already mentioned it is important for us to use the whole of society approach. So we have to really empower the community and etc. Okay, and there are some other keywords that need to be also mentioned here, which is sanitations of the environment to control of communicable disease, and also the educations of the individual in the context of personal hygiene. So if you look at TB and COVID-19, and also those countries, I think the previous speakers has already mentioned the list of countries that has high burden disease of TB. So most of those countries have issues with sanitations, and also of course with individual personal hygienes as well, like for instance in India right? So the core idea of ecological public health. So before I explain ecological public health, so there are at least 5 different approach of public health. Okay, so later we can probably also discuss, like in terms of, let's say, Muhammadiyah Jakarta, or maybe Universitas Islam Indonesia, right? UIN, UIN Jakarta. So probably in terms of the curriculum for students, so which approach we probably towards, or lean on. Okay, so because we have sanitary environmental public health, we have biomedical public health, social behavioral public health, techno-economic public health, and ecological public health. So if you look at this one here, there are a couple of differences, right? So sanitary environmental, so they are very much depending on, or very heavily, related to environmental approach, engineering approach. Biomedical, of course, it is related to health improvement that is requires understanding of biological causations, and socio-behavioral, and then techno-economic. So this is something related to economic and knowledge growth is prime elevator of health. So this is something related to economy. I think this is when a country says between health and economy, so we have to prioritize health. So that's why we don't want to have any lockdown, for instance. So economy has to be the main priority, for instance, right? And then the last one is the ecological public health. So ecological public health, so the core idea is that health depends on successful coexistence of natural world and social relationships. So there is a very close relationship between human and the environment, and also the social factors as well. So if you look at this one here, the key methods, I'm not going to read this in detail because probably the time is not that enough. But what I'm trying to say here, ecological public health is that it is draws upon and integrates parts of the other models. So ecological public health cross-cuts all other approaches. So sanitary, we have sanitations as well, biomedical as well, part of it as well, socio-behavioral, and also techno-economic. Yes, of course, economy is very important for health, right? So what we are trying to achieve here is to system analysis in order to manage social transitions and create healthy habitats. So how we can create healthy habitats in the context of course, populations of our people. So this is Ilona Kikbus. So Ilona Kikbus is also one of public health expert from Canada, if I'm not mistaken. So she said that public health is ecological in perspective, multisectoral in scope, and collaborative in strategy. So these are three important terminologies: ecological, multisectoral. So we need to work with other sectors in order to deal with a particular disease, and also we need to collaborate as well for us to implement our projects. However, according to Ilona, that this link between social change, pressure for social reform, and public health has been lost. So public health has over time lost its broad gauge approach and moved into a phase of medical dominance. Okay, so public health becomes so medical dominance. So they forgot to look at from comprehensive perspective or comprehensive pictures in dealing with a particular disease. So, and this is also quite relevant because we are currently in the Anthropocene era. So Anthropocene era is where human as the dominant factors in the world. Okay, so anything related to what happened in the world, it must be, or it could be related to human factors. That's why climate change, they add one word before climate change, which is anthropogenic climate change, because climate change is climate is changing because of human factors. So according to WHO report 2016, 12.6 million deaths each year are attributable to unhealthy environment. So, and of course, like this COVID-19 and also TB, something related to environment as well. And some, like an expert says that TB is a social disease or a socio-environmental disease because it is very, very close to socio-environmental determinants. And also WHO, this is the most recent report that offer 30 new human pathogens, new emerging infectious disease, 75% of them are originated from animals or zoonotic disease. So we have SARS, including HIV/AIDS, COVID-19. So which means there is a very close connections between human health, animal health, and environmental health. So this is the basic epidemiological triad or pyramida epidemiology. So we have agent, host, and environment, right? So this is the basic, factors. Whenever we have, disease problem, there must be, agent issue, host issue, and also the environmental issues. From the ecological public health, we can see the environment is sitting as the foundations. So if the environment is disrupted, so you can see the agent and host, there will be probably, close interactions between agent and host that will cause disease. And probably it is also not easy for us to manage the agent or the pathogen because the environmental factor is not, it's not within our reach to deal with. So from ecological public health, I think all of you have familiar with this image. So you can see the people, which is us here. So we are influenced by so many factors, because I remember when I was teaching in the classroom and I asked the students, what make you healthy? Okay, so probably this is something that we need to ask ourselves. What make us healthy? Healthy food, probably even like family support, right? So, and maybe healthy environment, a livelihood, right? So all this make us healthy. Religion, probably, spiritual support or spiritual energy that could lead us to healthy person. So all these are interconnected. So when we want to deal with, when we want to deal with a particular disease, let's say in our context now is TB and also COVID-19, of course, we also have to look at from all different aspects. Okay, not only from the pathogen or from the disease point of view. So this is just to give you an example. This is related to factors contributing to diagnostic delay. This is something related to, of course, the person, whether the person want to be diagnosed, whether they got, in this context, probably, let's say, COVID-19 or even TB. And health-seeking behavior is also still a problematic, factor at the moment in Indonesia. Some people, this is in the context of COVID-19, they don't want to be tested because they are afraid if they got COVID-19, because they said if I know that I got COVID-19, I'll become stressful, and that will make me worse. Okay, and also probably other factors as well, like stigma and also afraid and etc. So health-seeking behavior is very important as well to look at, because otherwise, if we in terms of testing, or surveillance is not really, if it is not really proper, so it is difficult for us to see, the magnitude or to understand the real picture of TB in our country. So TB incidence. So this is also based on the an article that was published in American Journal of Public Health. So we have directly observed treatment short course, so DOTS. So TB incidence rates appear more closely correlated with social and economic determinants, such as Human Development Index, access to water, sanitation, and child mortality, rather than to the success of DOTS. So according to this research, that for us to reduce the incidence of TB, it is important for us to think about, our approach in regards to social and economic determinants, not only DOTS. Of course, DOTS are important. However, according to this research, this is something that we also have to approach as well. Of course, when we talk about DOTS, there are 5, and this is also from the same journal, American Journal of Public Health. There are 5 elements or key success factors for DOTS. And the first one is political commitment. So political commitment is very important to make sure that we have enough support. So then, for instance, in Indonesian context, the hospital, the puskesmas, and also at the community level as well, they support the implementations of DOTS. Okay, especially, to avoid any misuse of antibiotics and etc. So I think previous speakers has already mentioned about MDR, multi-drug resistance TB, and we also have sorry, my son just came in. Okay, and we have, like, for instance, there's a slow progress in tackling MDR TB. Like only 1 in 4 of MDR TB cases diagnosed. Okay, and we can see here, especially in the context of new problems, because in the future probably we also have issue with antimicrobial resistance or superbug MDR TB. Okay, what about iatrogenic effects? In Australia at the moment, this is in the context of COVID-19 patients, which is the impact of medical treatment or of a particular disease. In Australia, we are now concerned about iatrogenic effects of COVID patients. And this is something that we also need to look at in Indonesia as well, because this could lead to another problem in the future as well, to that particular patients and also to the community as well, especially the misuse of antibiotics. Because as you know, Indonesia is quite, not Indonesia in terms of the country, but most people say people in +62 is quite, most of them are quite creative. So they probably can treat themselves, or they can buy medicines, they can buy antibiotics without prescriptions. They can access those antibiotics and they think, oh, this is a very good antibiotics for us. A lot of friends, they survive with these antibiotics. So then let's buy this, and then they can access that. So this is something that we need to make sure that we have to stop this practice. And I'm not going to talk this in detail, but this is Alexander Fleming has already mentioned. There is a time where people, danger. There is a danger that the ignorant man might easily underdose himself, and by exposing his microbes to non-lethal quantities of the drug make them resistant. So this is where people become creative and they can then try to treat themselves without seeing doctor. Okay, so this is a lot of things that cause antibiotic resistance. And of course, not only from the medications, but also now antibiotics. Also, they use antibiotics in agriculture, cattle. So when we eat meat, when we eat vegetables, they all contains antibiotics, and that will also influence us as human as well. So Indonesians in the Olympic 2020, in the context of archery, I think they did quite well, but unfortunately, we didn't get the medal. However, what I'm trying to say here, how far arrow can shoot is depending on how we pull back the arrow. Okay, so we have to pull back the bow. Sorry, we have to pull back the bow. So what I'm trying to say here, we need to look at from the upstream thinking of health intervention. So if you look at this one, this is the picture of people drowning from the upstream levels. So here we are trying to save these people drowning. But when we only think about the downstreams, what we are dealing with, so we are dealing with disease outcomes only, illness, people dying, so this is where if we only focus on downstream approach. So we also have to climb up the hill and then looking at the upstream levels, why people jump themselves to the river, how we can prevent them from jumping to the river, so then there is nobody, there's no one in the water. Okay, so how to solve a problem before they happen. So this is something that we need to do. So moving healthcare upstream. So if you look at this one here, so basically we also have to go upstreams and looking at the community impact. And then in the context of TB and also COVID-19, what need to be done in the context of policy, what need to be done in the context of social environment, to make sure that we can deal with this kind of problem in the long run. So there is a very good articles that just been published a couple weeks ago, which is this is published in a pulmonology journal, and they say that COVID-19 and TB, they are different disease, but they have the same challenges. So if you look at this one here, to TB and COVID-19, they all have issue related to socioeconomic status, housing and environmental conditions like overcrowding, urban and rural settings, poor housing and environmental conditions, right? Physical environment, environmental safety, food insecurity and malnutrition, cost and distance, social protections, culture and languages, access to healthcare. So if we really want to deal with COVID-19, of course, with COVID-19, TB and also with COVID-19, we also have to think about how we can manage all these social determinants. So that is why in the beginning we mentioned that we have to work with other sectors to make sure that we can achieve our goal, because otherwise, if it is only health sectors to deal with all this multi-complex or multi-sectoral approach, it is not possible for us to do so. So we really have to involve other people as well. And in the context of this is published by UNDRR, United Nations Disaster Risk Reductions. They say any pandemic or any acute events will interact with any chronic stresses. So which is what we call by pre-existing health conditions. So let's say if Indonesia is endemic to TB, now we have COVID-19. So there is interactions between endemic disease and now pandemic. And even now they probably say even COVID-19 will become endemic in the future. We don't know, okay? So, but with this interaction, so that will create a complex problems. So that is why resilience has to address the system of the system. So we really have to make sure that we involve all sectors to make sure that we can have a better positions to deal with, let's say, TB in the context of COVID-19. And also a U-shaped approach, which is a top-down by government help the community, community help other community, which is side to side, and also bottom up. So in the context of TB as well, so government also need to lead the process of TB prevention project or programs, and then and then the community need to help the other community, and then the community can provide feedback to the government. So any feedback to the government critic is something that we basically need. So that's why they call it a U-shaped approach. So everyone needs to be involved. Just take one example, like tobacco as a risk factors, right? In Indonesia, tobacco is the fourth highest risk factors for health, right? And the fact that 5 countries with the highest TB, like for instance, India, they also have high cigarette consumptions, suggest that controlling cigarette consumptions may reduce the risks of TB infections and also the occurrence of new cases. And tobacco also have issue or could also influence COVID-19 patients as well because of the lung, it will worsen the lung conditions, right? So this will help Indonesia achieve the goal of TB eliminations by 2030, as well as, of course, to reduce the non-communicable disease. But we just ask ourselves, so how consistent, or what about our commitment to eliminate tobacco in Indonesia, because Indonesia is quite high in terms of adult tobacco prevalence. So community resilience is something that we need to think about. So how we can make sure that the community they are healthy, and then we have a very strong healthcare systems, and also responsible governance, and also a prepared systems as well. Not to mention as well a strong economy. So we probably need to have like a project, or a small project in a small city or a small region, for instance, how we can make sure that everything is in place, and then we can see what we can do. Because I think Indonesia as a country is very complex, but this is something that we can do. And I published a paper related to urban community resilience. This is in the context of Jakarta. And there are quite a number of factors that we we can make it happen. Okay, of course, with political support of the government. So last but not least, this is a takeaway message. So a public health policy or a health policy should follow the principles of equity, sustainable, and also conviviality. So conviviality is, which means that we also think about other sectors, and also preservations of the global environment. So like now we use a lot of face masks, maybe plastic waste is become increasing at the hospital. So this is something that we have to think about, how we can make sure that we can be healthy without providing harm or threat to the environment, because otherwise later the environment will cause another problem to us as a human. So thank you so much for your attention. So I really would like to see your comments and also probably questions. So I look forward to discussions. Thank you so much.
Okay, thank you, Dr. Kirby. Thank you very much for the presentation. And we have here several questions, many questions from the audience. I would like to read it by one by one. The first is from Ibu Fini Fajrini. The question to Dr. Fahri and Dr. Rizky: what is the current condition of TB in Indonesia? Increase, decrease, or the same? Or is it because, or is it biases because it loses prestige with the current COVID, which is the more dangerous, TB or COVID? Please, Dr. Fahri, maybe first to answer the question, and then Dr. Rizky.
Thank you very much. Can I answer in Indonesian?
Of course.
Yeah. Pertama, COVID tuberkulosis masih menjadi penyakit endemis di Indonesia. Kasusnya masih sangat tinggi. Ditambah lagi dengan kesadaran dari pasien yang curigai tuberkulosis maupun yang menderita tuberkulosis mengobati diri dan memeriksakan diri. Karena rendahnya kesadaran itu dapat membuat rendahnya angka pasien yang terdiagnosis, sehingga itu adalah fenomena gunung es yang banyak sekali pasien yang terkena tuberkulosis tapi terdiagnosisnya tidak terlalu banyak. Yang datang ke klinik pun juga sudah tinggi jumlah kasusnya sampai sekarang. Terkait dengan masalah COVID-19, COVID-19 juga endemis di Indonesia, bahkan pandemi di seluruh dunia dengan daya penularan yang sangat tinggi. Apalagi dengan pasien dengan COVID-19 disertai tuberkulosis, itu memperburuk prognosis dari pasien tersebut. Apalagi terkait dengan komorbid lainnya, misalnya diabetes mellitus maupun HIV dan sebagainya. Kalau dikatakan mana yang menjadi berbahaya di antara keduanya, dua-duanya termasuk penyakit yang infeksi yang berbahaya, dan dua-duanya mesti diatasi. Apalagi dengan COVID-19 terkait dengan pengobatannya. Untuk COVID-19 sampai sekarang belum kita temukan drug of choice-nya. Oleh karena itu proses penyembuhannya pun sampai sekarang belum kita bisa ketahui dengan pasti. Saya rasa itu jawabannya.
Terima kasih Dr. Fahri.
Menjawab.
Mungkin Dr. Rizky ingin menambahkan dari pertanyaan tersebut. Silakan Dr. Rizky.
Ya, terima kasih banyak atas pertanyaannya. Jadi kalau kita melihat laporan dari WHO itu dibandingkan bulan Januari sampai Juni, notifikasi terhadap pasien kasus TB itu lebih rendah dibandingkan tahun sebelumnya. Begitu juga data laporan yang disampaikan Januari sampai November itu juga masih terjadi penurunan notifikasi terhadap kasus-kasus TB. Nah, kalau untuk mana yang lebih berbahaya, semuanya kalau dalam penanganan yang tidak adekuat, dua-duanya cukup berbahaya. Karena TB sendiri merupakan salah satu penyakit yang memang dibarengin dengan bersama-sama dengan komorbid yang cukup banyak, biasanya yang datang dengan kondisi yang berat. Ditambah kita juga banyak menemukan kasus COVID-19 yang bersama-sama dengan infeksi tuberkulosis, yang biasanya terkadang kita juga melihat terlalu terfokus dengan infeksi COVID-19 sehingga gambaran-gambaran TB yang sifatnya tidak menampakkan gambaran kavitas, terkadang kita melewatkan diagnosis TB itu sendiri, sehingga COVID-19 diobati pada saat 7 hari evaluasi itu terlihat ronsen torak perburukan. Nah, ini yang mesti kita sadari dari awal dengan menggali lebih dalam, wawancara yang cukup detail terhadap faktor kontak baik itu TB maupun COVID-19, sehingga kita dapat memberikan terapi sedini mungkin untuk TB-nya sehingga tidak memperberat COVID-19-nya. Mungkin itu tambahan dari saya. Terima kasih Bu Munaya.
Yeah, the next question from Dinda. As we know, in Indonesia, there are still many people who are still difficult to educate about COVID. Some even say that COVID is just an ordinary disease. They also said that the news that broadcast news of that due to COVID was actually only because of another disease. So how can the public want to be educated and most importantly believe in this pandemic? Kepada siapa? Mungkin kepada 3 narasumber kita, please untuk memberikan responnya. Siapa dulu? Mungkin Dr. Fahri dulu, kemudian Dr. Rizky, setelah itu Dr. Feby. Jadi
Ya,
bagaimana? Silakan Dok.
Ya, silakan yang lain dulu.
Dr. Feby mungkin. Silakan Dr. Feby.
Baik. Ini pada pakai bahasa Indonesia, saya pakai bahasa Indonesia juga deh.
Iya, kangen ya Dok ya. Di Australia pakai bahasa Inggris terus kan ya Dok ya.
Itu tapi ada pertanyaan yang tadi belum dibacakan ya dari Vini Fajriani kaitannya tentang how is the case of TB in Australia.
Yeah.
So in Australia, if I'm not mistaken, I think the most recent one is 5.3 per 100,000 populations. So there is still TB in Australia, and most of the cases are imported cases. However, that's why in Australia is very the border is very strict ya. Jadi kalau mau ke Australia itu, kalau mau tinggal kalau kecuali hanya untuk tinggal sebentar ya, seperti turis, mereka tidak harus fototoraks, tapi kalau student itu harus fototoraks, dan kalau ada flex sedikit pun itu tidak diterima, visanya tidak di-approve. Dan bahkan kalau misalkan sudah sembuh dari TB, itu kalau ada riwayat TB-nya, mereka tetap harus diperiksa setiap 6 bulan oleh di rumah sakit infeksius, khusus untuk TB. Gitu. Contohnya juga misalkan di sini anak kecil itu tidak wajib vaksin BCG, ya. Tapi karena anak saya lahir di sini dan saya Indonesia, dari Indonesia, maka dia mengatakan bahwa anak kamu harus divaksin BCG karena kamu pasti akan ke Indonesia, dan Indonesia adalah endemik TB. Jadi dia divaksin BCG. Sementara kalau orang Australia yang lainnya itu tidak divaksin BCG. Jadi itu salah satu contoh ya, dari mulai vaksinasi, mulai dari imigrasi, border itu diperketat. Jadi mencegah tidak adanya importasi kasus. Sementara kalau kayak di Indonesia kan kasus import COVID-19 aja masih diterima gitu ya. Jadi luar biasa, kita belum berhasil memanage community transmission, tapi kita masih menerima import kasus dari luar negeri. Nah, kalau di Australia mereka mengatakan bahwa kita tidak sanggup untuk menangani community transmission, makanya bordernya ditutup rapat, baik COVID-19 maupun TB. Ada seorang teman saya sudah 1,5 tahun ya. Jadi dia sudah ke sini duluan, istrinya masih belum bisa visanya karena ada TB gitu. Tapi sebenarnya dia sudah dalam pengobatan, jadi tapi masih ada flagnya. 1 tahun berjalan, TB-nya sembuh, sekarang ada COVID-19. Jadi istrinya sampai sekarang masih belum ke sini, sementara PhD-nya udah mau selesai, 3 tahun. gitu. Jadi dia jomblo lokal kita sebutnya, ya. Itu karena mereka benar-benar tertutup sekali, sama sekali tidak mau menerima kasus dari luar. Mungkin itu. Nah, kaitannya tadi tentang pertanyaannya tentang edukasi. Makanya di sini kita harus melibatkan tidak hanya teman-teman public health ataupun teman-teman dokter, tapi juga teman-teman yang memahami antropologi, sosiologi, dan seterusnya. Tentang bagaimana kita bisa memahami bahasa yang bisa diterima oleh masyarakat, dan bahkan mungkin juga melibatkan saya tidak mau menggunakan istilah ini, tapi influencer gitu ya, tapi mungkin lebih kepada tokoh-tokoh masyarakat lokal gitu. Jadi bukan artis gitu. Jadi artis atau kita tokoh-tokoh masyarakat lokal yang bisa diterima di masyarakat tersebut, dan pendekatannya tidak one size fits all. One size fits all itu artinya dari Sabang sampai Merauke sama, harusnya tidak. Karena mungkin pendekatan di Aceh berbeda dengan Papua misalkan seperti itu. Jadi pendekatan edukasi pun harus benar-benar bisa disesuaikan dengan budaya lokal. Mungkin itu teman-teman dokter yang lainnya mungkin nanti bisa menambahkan. Silakan.
Bagaimana dok, Dokter Rizky atau Dokter Fahri mengenai edukasi mengenai COVID ini? Masih banyak yang tidak percaya kalau ini COVID. Ya. Silakan.
Ya, memang itu masih menjadi masalah di kita, terutama di Indonesia. Terutama di sebagian besar di wilayah, di daerah, yang artinya di daerah itu di luar Jakarta. Masih banyak orang-orang yang tidak percaya akan ada atau tidaknya kuman COVID, virus COVID-19 ini. Dan itu tidak hanya di tingkat masyarakat biasa, tapi di tingkat pemuka-pemukanya pun masih belum percaya. Baru setelah kena atau terinfeksi, baru mempercayai bahwa COVID itu ada, dan berusaha agar tidak kembali tertular. Nah, tadi dikatakan oleh Pak Feby memang banyak pendekatan-pendekatan yang bisa dilakukan. Tadi tidak hanya melalui penjelasan-penjelasan atau penyuluhan-penyuluhan, tetapi betul dikatakan pendekatan melalui tokoh-tokoh masyarakat, tokoh-tokoh masyarakat yang diberi dahulu pengertian, diberikan dahulu masukan-masukan agar memahami tentang bahayanya COVID-19 dan seterusnya. Kemudian baru masuk ke tingkat masyarakatnya. Yang lain bisa dengan melalui jalur pendidikan, misalnya melalui sekolah-sekolah atau lainnya, melalui kegiatan-kegiatan yang ada di lingkungan suatu masyarakat. Saya rasa itu tambahannya, Bu Naya. Terima kasih.
Terima kasih dok. Terima kasih Dokter Fahri. Silakan Dokter Rizky untuk memberikan respon untuk pertanyaan ini.
Ya, terima kasih Bu Naya. Sebenarnya untuk penjelasan dari Dokter Fahri dengan Pak Feby itu udah cukup komplit ya. Tapi mungkin saya ingin berbagi saja ini. Beberapa kali memang saya merawat pasien-pasien COVID-19 itu, termasuk ada beberapa yang memang influencer di sosial media. Nah ini mereka memang berangkat, ada yang mulai tidak percaya atau memang ada yang percaya, karena aktivitas yang mereka lakukan itu tetap sering dan tetap terkadang ketatan dalam menjaga protokol kesehatan juga cukup tidak salah juga kita melihat bahwa ketidakpercayaan masyarakat terhadap COVID-19 itu karena COVID-19 ini agak sedikit luas pembagian secara klinisnya, mulai dari orang yang tidak bergejala sampai orang yang bergejala berat. Artinya kalau dia terkena dengan kondisi tidak bergejala, tentu saja dia tidak akan merasakan bahwa dia terinfeksi dari COVID, yang dia akan menganggap bahwa COVID itu merupakan suatu penyakit yang diada-adakan, apalagi berangkat di awal memang sudah tidak percaya terhadap COVID itu. Tapi ada orang yang berat dan kemudian dia sehat, dan dia bisa menjadi salah satu edukator yang paling baik terhadap COVID ini, apalagi memang basicnya sebagai influencer atau pemimpin pemuka agama. Nah, jadi kita memang melihat dengan kondisi tersebut, dilihat secara klinis itu range-nya agak sedikit luas, kita perlu melakukan edukasi yang cukup masif terhadap masyarakat bahwa kondisi COVID-19 ini memang benar-benar ada dan memiliki risiko. Apalagi kita melihat di data COVID-19, angka kematian yang terus meningkat dan terjadi di seluruh dunia. Nah, ini yang terus kita sadarkan bahwa COVID-19 itu memang merupakan tetap ancaman. Tetapi karena itu saya beranggapan bahwa memang ketidakpercayaan tersebut karena permasalahan di dalam edukasi kita. Mungkin dari saya tambahannya itu.
Oke, baik. Thank you, Dr. Fahri, Dr. Rizky, Dr. Feby, but we still have another question from Ibu Dewi Purnamawati. I would like to ask to Dr. Feby what you can suggest for the best prevention and intervention for TB care in Indonesia as your presentation about ecological factor. What the best practice that we can do, we can adopt to reduce TB in Indonesia. Please, Dr. Feby.
Baik, terima kasih Bu Munaya. Thank you, Mbak Dewi. I think this is a very good questions, and something that we have to believe there is no I mean, every country has their own uniqueness. Yeah, so jadi if there is any, like, let's say, although maybe WHO has already mentioned they have best by, WHO best by or best practice, but I think every country need to have their own uniqueness when they develop an approach to deal with a particular a specific disease, let's say TB. Jadi di Indonesia ini sebenarnya mungkin sudah menggunakan ya, karena kan memang sudah ada policy kebijakan kaitannya tentang bagaimana untuk treatment, terus memastikan agar si pasien meminum obat dan seterusnya, itu semua sudah berjalan. Cuman yang penting yang mungkin harus dipastikan adalah bahwa pelaksanaan ini harus dilaksanakan secara komprehensif dengan seluruh artinya sektor itu juga terlibat. Makanya kalau kita menggunakan pendekatan Ottawa Charter tahun 1986 misalkan, maka ada 5 aspek yang harus diikutkan, misalkan dari polisinya, dari polisi kebijakan itu harus jelas ya mengenai kebijakan vaksinasi dan seterusnya, itu harus jelas, masyarakat harus paham itu. Yang kedua adalah environment, jadi environment itu dipastikan bahwa hygiene, sanitation dan seterusnya itu bisa pelan-pelan kita perbaiki. Yang ketiga adalah community support, karena ini jelas bahwa ketaatan atau kedisiplinan pasien minum obat itu tidak lain dan tidak bukan adalah karena memang community support, keluarganya dan sebagainya. Yang ketiga, edukasi masyarakat. Nah, edukasi masyarakat ini juga harus dilakukan, individual skills. Yang keempat, tadi individual skills. Jadi untuk mematahkan kalau ada isu-isu yang hoax, misinformasi, disinformasi dan seterusnya, maka ini harus menggunakan tentunya teman-teman dari sektor pendidikan dan seterusnya, ini harus terlibat di situ. Dan yang kelima adalah reorientasi health services. Jadi reorientasi di sini maksudnya adalah pendekatan kesehatan masyarakat yang memang berbasis prevensi atau berbasis mencegah. Nah, itu yang harus dipastikan, kan risk factors-nya jelas. Risk factor TB itu apa saja dan bagaimana kalau sebisa mungkin sebelum orang tersebut terjangkit TB, kita bisa mengurangi risiko yang ada sehingga akhirnya orang tersebut tidak harus terjangkit TB. Mungkin demikian Mbak Dewi. Terima kasih.
Thank you, Dr. Feby, for the answer. And I think I really want to continue this discussion. This is very valuable, but unfortunately, we have a limit in time. I'm not going to conclude about our session today, but I would like to ask for a closing statement for the first speaker, our great speaker. Maybe from Dr. Fahri first, closing statement, and then Dr. Rizky, closing statement, and Dr. Feby. Please, Dr. Fahri.
Yes, both of the TB, tuberculosis, and COVID-19, ya, dua-duanya ada penyakit infeksi yang berbahaya, dan dua-duanya bisa terjadi berbarengan pada pasien-pasien, dan dua-duanya memiliki gejala yang hampir mirip, dan perlu tindakan pencegahan dari masyarakat terkait dengan pematuhan pencegahan dan protokol dan sebagainya. Dan pengobatannya masih belum ada drug of choice-nya untuk COVID-19. Sementara tuberkulosis sampai saat ini masih merupakan penyakit endemis dengan indeks kasus yang sangat tinggi. Oleh karena itu kebiasaan hidup yang baik dan bersih dan menjaga kesehatan dan protokol terkait dengan COVID itu mesti harus kita terus lakukan. Saya rasa itu. Terima kasih, Mbak.
Thank you, Dr. Fahri. Please, Dr. Rizky, for your closing statement.
Oke, terima kasih. Jadi mungkin sebagai penutup saya mungkin mengingatkan lagi bahwa setiap gejala respirasi, keluhan respirasi dan penyakit yang melibatkan sistem pernapasan, baik itu bagian atas dan bagian bawah, kita tetap sadar terhadap kemungkinan infeksi COVID maupun infeksi tuberkulosis, dan tetap dalam alur pengobatan dan memberikan edukasi yang baik terhadap masyarakat. Karena kita yang berada di sini merupakan edukator-edukator yang baik untuk masyarakat. Terima kasih. Assalamualaikum.
Thank you, Dr. Rizky. And our last speaker, please, Dr. Feby, for the closing statement.
Ya, terima kasih Mbak Munaya. Pertama saya senang sekali bisa ketemu secara online dengan Dr. Fahri dan Dr. Rizky ya. Kesempatan ini insya Allah nanti mungkin kita bisa berkolaborasi lagi di kedepannya, dan ada kakak kelas saya Mbak Muhammadiyah ya, mungkin juga menjadi panitia acara ini di sini. Yang terakhir yang mau saya sampaikan adalah pentingnya bagi kita untuk leadership efektivitas dari kepemimpinan itu sangat penting, khususnya dalam kesehatan masyarakat. Itu sangat penting sekali, dan kita lihat saja misalkan contohnya di Amerika, perbandingan antara Trump dengan Biden itu berbeda sekali dalam penanganan COVID-19. Makanya di sini kita juga perlu sebagai pejuang-pejuang kesehatan ya, apapun profesi kita, kita menjadi sangat penting sekali peran kita dimanapun kita, agar kita bisa menjadi pemimpin dalam bidang kita masing-masing, sehingga akhirnya semoga kita bisa membuat sebuah program kesehatan yang bisa tidak hanya menyelesaikan permasalahan yang ada di lingkungan kita, tapi juga bisa bagi bangsa dan negara kita. Dan untuk teman-teman mahasiswa dan kolega-kolega akademis, mungkin penting bagi kita untuk memanfaatkan kesempatan kita sebagai akademisi untuk melakukan riset bagaimana agar lebih baik, dan ini pendekatan TB, COVID-19, dan juga bisa memberikan masukan yang terbaik bagi bangsa dan negara kita insya Allah. Mungkin demikian, terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Again, I thank you very much to Dr. Fahri, Dr. Rizky, Dr. Feby for your valuable sharing and great speaker with great material. To express our appreciation, we would like to give the speakers the certificate of appreciation. Committee, please. Please share the certificate. First to Dr. Fahri, and the certificate for Dr. Fahri, please, the committee. Okay, certificate presented to Dr. Muhammad Fahri in recognition and appreciation of your contribution as speaker at the first Muhammadiyah International Public Health and Medicine Conference with the theme Management for Tuberculosis Control During COVID-19 Pandemic. Please, Dr. Fahri.
Thank you very much for the committee and Bu Munaya.
Thank you very much. And the second certificate to Dr. Rizky. I give you the certificate to Dr. Rizky Afaputra. Thank you for the contribution to this conference. Thank you very much for valuable sharing, for great speaker, great material. Thank you very much, Dr. Rizky.
Ya, terima kasih.
And the third certificate for Dr. Feby. Dr. Feby, mungkin adik kelas saya waktu di UI dulu ya, Dr. Feby. Saya dulu di UI tahun 98 S1-nya.
Oh, ya berarti kakak kelas saya.
Saya S2-nya 2002. 2002 lulus 2004. Iya, dan mudah-mudahan nanti bisa ke Queensland ya, main ke sana.
Insyaallah. Nanti saya jemput di airport insyaallah semuanya.
Amin, amin ya rabbal alamin. Mana sertifikatnya untuk Dr. Feby, panitia? Panitia, sertifikat untuk Dr. Feby, please.
Enggak apa-apa, lagi di print mungkin.
Oke, nanti kami kirimkan sertifikatnya kepada Dr. Feby. Mohon maaf atas kesalahan teknis. Oh, ada nih, ada. Oh, ada. Oke, ada. The certificate presented to Dr. Feby Dwi Rahmadi SKM MSc PhD in recognition and appreciation of your contribution as speaker at the first Muhammadiyah International Public Health and Medicine Conference, the time management for tuberculosis control during COVID-19 pandemic. Thank you very much, Dr. Feby. Please accept the certificate. And again, I thank you very much to Dr. Fahri, Dr. Rizky, and Dr. Feby for your valuable sharing. Thank you very much, and perhaps we can meet another time, another conference, or in another seminar. And okay, thank you for all of the participants. Please let me remind you that after this day, we still have another day tomorrow, and on Friday, which the participant will present their result of the research in our parallel session. Okay, so don't miss yes, tomorrow. Yeah. I, Munaya Fauzia, would like to say thank you very much for your time and your valuable time being with us with our conference. And I give it back to the MC, Karimah and Dinda. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Terima kasih, Pak Feby.
Terima kasih, Dr.
Rizky.
Terima kasih. Terima kasih.
Terima kasih, Mbak Munaya.
Thank you for our Mrs. Munaya Fauzia, Bachelor and Master of Public Health, for greeting the event in this conference. The speakers are amazingly great. Hopefully what the speakers has described will get a blessing and become charity in hereafter.
Alhamdulillahirabbil alamin, we have arrived at the end of the first conference sessions. In the first Muhammadiyah International Public Health and Medicine Conference, hopefully the material given today can be useful for us. We would like to thank for the presenters, committee, and participants who have taken the time to attend conference today. And the announcement, this conference will have a tag in 2 days. They're on Thursday, 29 July 2021, and tomorrow on Friday, 30 of July, which is tomorrow for the presentations of research results from each participant at 9 a.m. Then for the room of moderators from Mrs. Narila, Mrs. Dewi, Mrs. Triana, Mrs. Triastika, and Mr. Baikuni, it will start at 11 o'clock because there has to attend the inauguration IACME event. And don't forget to open and reread the program book of this conference. Thank you.
Don't forget to keep running the health protocol wherever we go. Keep the spirit and see you tomorrow for the second session in the first Muhammadiyah International Conference For Muhammadiyah International Public Health and Medicine Conference, we are as a master ceremony conference today. Apologize profusely if there are mistakes in both words and actions. And the last we said,
Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Dr.
Terima
Fahri.
kasih semua.
Terima kasih Bu Deka.
Terima kasih semuanya, makasih.
Terima kasih peserta.
Ya, makasih Pak Febri, makasih juga yang Australia ini semuanya, terima kasih. Sampai ketemu yang akan datang lagi.
Sukses Bu Deka. Terima kasih.
Sama-sama.
Sukses Ibu Dekan, sukses semua. FKM UMJ.
Inli.
Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah menanti padamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah menanti padamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah menanti padamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat. Bersama Fakultas Kesehatan Masyarakat Universitas Muhammadiyah Jakarta, bergerak terus mencegah penyakit, mempromosikan hidup sehat. Sehat adalah anugerah melalui padamu. Sehatlah jiwa raga kita, bangunlah peradaban untuk nusa bangsa. Hari-hari berjalan menantang matahari, melawan gemuruh ombak. Hanya satu hasrat dan cita-cita, masyarakat hidup sehat.